is very associated with any type of fundoplication procedure. So that means we are not comparing poem plus fundoplication versus laparoscopic procedure. So it is, I believe it is not fair to compare this in head-to-head basis. Now, we also understand that reflux is not only due to myotomy, because there are several risk factors that predispose to reflux. So these are the risk factors that can lead to reflux procedure, and not only the myotomy. So these are also the factors. And nowadays, with the availability of effective PPI, PCAPs, we can very well control the reflux symptoms, one. And number two, we have various endoscopic procedures like arms, where we can also manage the post-endoscopic reflux. So in laparoscopic hilar myotomy, what they were doing previously was the Nissan's, that is the complete fundoplication. However, this also resulted in another ominous complication like gas plot syndrome, which was in fact more problematic in the patient than the symptoms of the achalasia itself. Nowadays, what has been doing along with the LHM is the partial fundoplication. So along with that line, in 2019, again, there has been a modification in the procedure. So now they are using poem plus fundoplication in the same setting. So this is a poem plus F. So hopefully, if we can compare the data between the poem F and the LHM, then I think we can really identify the incidence of reflux in these patients. So all that I want to say that is, even if there is a reflux, we can manage it either by doing some intraoperative procedure or by doing later procedures like ARMA or ARMS. So to summarize, I think the management of achalasia cardia has evolved tremendously over the centuries, starting from this is a picture of Sir Thomas Willis doing the dilatation of the lower esophagus using the whale bone and the sponge. It was a very crude method, to the advent of POEM in 2008. And in less than 2 decades, POEM has demonstrated remarkable success. And with the introduction of POEM plus fundoplication, it is clear that we are not just only moving forward, but we are redefining the standards of care. And medicine means progress, and it is in embracing the newer technology and not clinging to the old technology only. So hence, I think POEM is here to stay, and it will be there. Thank you.
Thank you, Dr. Vinod Karki, for excellent presentation regarding POEM. Next speaker is Dr. Janendra Kumar Chaudhary. He is Chief Consultant Surgeon in Surgical Gastroenterology, Department of Surgical Gastroenterology in NAMS, and he is at present coordinator in MCS program, and he is the very good surgeon I have ever seen. Welcome, Dr. Janendra, to put points regarding laparoscopic Ehlers myotomy.
Good afternoon, everybody. I must congratulate the organizer for putting this great academic session, and thank them for having me here. So I am here to put my point. So I have nothing to disclose except that presenter is surgeon. So he might be biased towards his procedure. So, but I'll try to convince you that why this is like standard and why it should stay. So, as our previous speaker spoke, that going back to history, we must acknowledge this person, who is Sir Thomas Willis. He has a lot of work. If we see in medicine, he has a lot of work. If I'm not wrong, then in neuroanatomy also, there is the circle of Willis in his name. So he first reported this case of this achalasia almost 350 years back, and that the name achalasia was given in 1972 by Horst. So this is the diagnostic workup of one of our patient who underwent laparoscopic Heller's cardiomyotomy. So basic investigation, what we all know is esophageal manometry, which is the gold standard considered now. But previously, without that, when it was not available, we used to rely on barium esophagogram, and to exclude the malignancy or pseudoachalasia, the endoscopy used to be done. And another newer procedure is for diagnosis is flip. So just to show the different type of achalasia, our patient fall in this type 1 achalasia, where there was no pressurization, and there is, as in all achalasia, there was absence of relaxation of distal esophagus. So going back to the different modality of treatment, there are a lot of modality. Out of that, in case of low surgical risk group, less than 45 year, myotomy is the procedure of choice, and that can be done with different approach, as previous speaker spoke. So why, and looking at the guideline, what the guideline says, that SAGE's guideline, it recommends Heller myotomy with fundoplication. ACG guideline 2020, it also recommends Heller's myotomy with fundoplication. And says that it has got less reflux. And recommendation 10 states that POEM compared with this other Heller's myotomy have got more incidence of GERD. So let's brush our anatomy knowledge from MBBS. What is the cause of GERD? As we all know, the main anti-reflux mechanism is by lower esophageal sphincter, and which is the cause of this achalasia cardia here. So we are dividing it. So whatever we are left is the other mechanism, the abdominal segment of the esophagus and angle of his. So by doing surgery, we have the opportunity to augment this. Or if there is like a hiatal hernia, we can correct this. So I am in favor of this. So come to this. Why lap Heller's myotomy with fundoplication? Because myotomy alone predisposed to GERD. Fundoplication limits the esophageal acid exposure. Hence, there will be less complication related to that reflux. And it eliminates the need for lifelong medical, though we can treat, we can say that we can treat GERD with medical therapy, but it we have to give that for a long time. So, and also, as I said earlier, surgical by doing surgical myotomy, if there is hiatal hernia, we have chance to repair that as well. So why there is why fundoplication? Why I am so much stressing on this? So there is one randomized trial, double-blind. So what does the observation says? Acid exposure time with only the myotomy is significantly higher in case of myotomy. And by adding the door fundoplication, there is significant reduction in pathological GERD in his study. And similar similar result is seen in another study, that is systematic review with meta-analysis, which again says that POEM, it has got almost twice, actually more than twice the acid exposure compared to laparoscopic Heller's myotomy plus fundoplication. looking at like different series, looking at them, the GERD following poem, it ranges from 18% to 58%, which is quite wide. And if you again look in detail, then they say like Eastern population, Eastern paper, they report the GERD towards left side compared to West. And this could be because of obesity. And again, looking at this impact of GERD on quality of life and productivity. Symptom is present almost in 40% case, and that will definitely hamper the quality of life and productivity of the patient. So, and looking at this long-term outcome of this two procedure, that is POEM and Heller cardiomyotomy. Though it looks like Heller myotomy, it has got a little bit higher this treatment rate. But the long term, it is like follow-up in Heller myotomy group is 5.3 years, whereas the follow-up in POEM is only 3 years. So maybe like in long term, the retreatment required in POEM group will also increase. So now the question is, like we can say that we can treat GERD symptom with medical therapy, but does medical therapy for GERD increase it? This intestinal metaplasia, does it increase or decrease? So what this study says that intestinal metaplasia favors the region of columnar line esophagus, that is most proximal. That is of lower esophagus, the proximal part of lower esophagus is affected more for this metaplasia. So what is the culprit? So from this observation, we can say that intestinal metaplasia is promoted by increasing the pH. That is, if we like prescribe more PPI, which increases the pH, so that can may cause more intestinal metaplasia, and which is like initial step for this esophageal adenocarcinoma. So to conclude, fundoplication reduces the post-op GERD after Heller myotomy using minimal invasive technique, eliminates the disadvantage of open surgery, and relief of dysphagia is similar in all myotomy, both in POEM or from this study it says. But myotomy alone treats one disease, but at the same time it inflicts the other disease. So, to my view, Heller myotomy with fundoplication is preferred procedure of Achalasia. And this is the picture showing one of post-op scar of our case. And I will leave you with this video. Sorry. Okay. So this is one of our case. Of laparoscopic Heller myotomy with door fundoplication. We are mobilizing the lower esophagus, putting that in a sling. And myotomy being performed, started. So myotomy can be like in the esophagus, like what we up to 6 to 8 centimeter we can do, and in lower esophagus around 2 to 3 centimeter. So after that myotomy, endoscopy is being performed. We can see the glow of light there before checking the leak, if there is any. And after that, we are preparing for fundoplication. Thank you.
Thank you, Dr. Jayendra, for your excellent presentation. Again, I invite Dr. Vinod Karki to keep his conclusion why poem is better than this to Heller's myotomy. Please.
Thank you, Dr. Jayanendra, for speaking for LHM. I think he has made my case more stronger because what he has shown is he is also doing the myotomy but with more scars and also the increased chance of repeat therapy. Now regarding the reflux, I think in today's world we can treat it medically or with even different endoscopic management. And as we are witnessing new modalities like endoscopic, poem plus fundoplication, so I think we have come a long way, and in less than 2 decades, poem has shown remarkable progress, unparalleled success, and hence there is no turning back. So I think what we are witnessing is the future, and future is poem. Thank you.
I agree with him in only one condition. If he adds endoscopically fundoplication, then I will be the first one to refer him my case for poem and endoscopic fundoplication. We can do that later. Yes.
We have consensus statement from chairperson. Expertise, both procedures are highly demanding. Learning curve, yes. Poem is new thing and it is developing. It is developed in 2008-9 and still poem F and other thing is going on. So it's still to follow up data and RCT, more RCT required. Outcome wise, both are same. Complication rate is more with poem. Nowadays, most of it is literature, but with expertise and with overcoming of the learning curve, this may be decreased. Recurrence of symptoms will take longer time in case of poem than in the laparoscopy Heller's myotomy, but longer follow-up is required because it is newly developed technique. Rescue procedure, yes, after failure of the Heller's laparoscopy Heller's myotomy, poem is rescue procedure because we can do longer myotomy in case of poem. Esophagitis and GERD more with the poem, but poem F will address it, I think, and research will show later on. And this is the more worrisome symptoms, especially in case of pediatrics and adolescent people, because chances of, as Dr. Janendra said, metaplasia, GERD is quality of life, because young adult and children cannot be put in a lifelong anti-reflux medication. Thank you.
Thank you, our speakers, for this wonderful session. Now, I would like to request our chairpersons to provide token of love and certificate to our speakers. I would like to request Dr. Sarat Pokhre to provide token of love to Dr. Jayanendra Chaudhary. Now I would like to request Dr. Bidanidhi Paudel and Dr. Rahul Pathak to provide token of love to Dr. Vinod Karki.
Thank you, sir. Now we move on to the next session, that is the ERCP session. To chair the session, I request the chairperson to come on stage, Dr. Ramiraj Shrestha, Dr. Pasan Sharma, and Dr. Rajesh Pandey.
Again, namaskar. Now we have this ERCP session. That we have this three speakers, and after the third speaker, the question answer session will be in proper way, and then we have the time constraint, and only the few questions are allowed. And if you have any query, you can ask in the dinner session or tea break. Okay, the first we have a first speaker, Dr. Ram Gurung, and he doesn't need any introduction. He is an endoscopic man, and he is going to talk on this selective biliary cannulation.
Good afternoon, ladies and gentlemen. Thank you, Madam Chairperson, for your kind words. My topic today is selective biliary cannulation. I believe there are many here who are doing ERCPs, ranging from just beginner to highly skilled experts. Maybe experts can add if I have omitted anything important at the end of my presentation. Selective biliary cannulation is first and foremost and most crucial step in biliary intervention. Although an expert can achieve cannulation in more than 95% of times, it is not without difficulty. Around 20% of the time, cannulation is very difficult, and without employing alternative techniques, it is difficult. So I hope in this short presentation, this is going to be useful to some extent. First thing, when we get to the duodenum scope, and we have done shortening of scope, is to identify the papilla. We really have to spend some time to locate the papilla and to position our scope and to stabilize the second part of duodenum. It is not that difficult to identify the papilla unless sometimes, especially the type 2 papilla, very small papilla, or the papilla with large, diverticulum, in which case papilla may be hidden inside, or sometimes the very small papilla may be hidden with the folds. So the landmarks, how you identify papilla is, you have to know the anatomy. Mostly, if you follow the vertical folds, number 2 shown here, also called the frenulum, and the orifice is most of the time obvious, and infundibulum, the bulged part, is very helpful to be identified. So after identifying the papilla, we have to then plan our cannulation. So these are the important cannulating accessories. We have, I think all of us know, we have two techniques: guide wire assisted cannulation and contrast assisted. Here I will be describing the guide wire assisted technique. To be honest, I have never had to use the contrast assisted cannulation technique. Data also supports the guide wire assisted technique. And we all start for the primary cannulation with sphincterotomy and the guide wire. And in choosing guide wire, it is important to choose the hydrophilic guide wire. You can use straight tip or angle tip. Sometimes the angle tip guide wire helps, especially in the, if there is a difficulty, and for which you need to have a good assistant also. And the advantage of using sphincterotomy is that over cannula, standard catheter, is that it is flexible. The tip can be flexed and can be aligned to the axis of CVD, and it's also time saving. You don't have to exchange like in catheter, so time saving also. Guide wire assisted technique, you can either engage your cannulating catheter or sphincterotomy 1 or 2 millimeter inside, and then push the guide wire. Or sometimes if the orifice is very small, you can actually take help of guide wire. You can protrude the guide wire around 1 to 2 millimeter and take that as a guide, as a road map. So you can do that. So sometimes for a very small papilla, I use taper tip catheter, like shown here in number 5, which has got a very small, slim, tip, and it is easier. The only drawback is that sometimes if you use it not gently, then it might, cause trauma to the papilla. यसमा कुन चाहिँ आयो भिडियो आउने सरी यो माउस हैन भिडियो ओके यो अर्को एकछिन सरी नेक्स्ट स्लाइड या थ्यांक यू प्ले भएन है pen drive. Yeah, okay, sorry for this. The video is not playing. Here I actually would like to show you the video of very moving active duodenum and with very fast respiration. And this patient we observed for about 5 minutes, but the duodenum was not amenable. So we gave Buscopan, 20 milligram Buscopan. 3 minutes later, the duodenum was quiet and we could cannulate in a single attempt. So it is also important to not to hurry or prompt the cannulation at once. You have to stabilize the duodenum. Sometimes you need to give simethicone solution if there is excessive air. Or if the duodenum is moving, you need to, remove the spasm by giving Buscopan. So the position, next is position. The position of your, cannulating device to the ampulla it's the most important thing, I think, to do, in order to achieve the cannulation. You should always keep your ampulla at 12 o'clock position, 11 to 12 o'clock position. And your cannulating device should always be from the right-hand side and from below upward. So in order to achieve this position, you need to adjust your movements. Normally I do right turn, clockwise turn of my scope and little push, which brings your ampulla to the desired position. I hope this video plays. No, not playing. Okay, so here I wanted to show you the position of the cannula axis of the cannula to the intramural part of the duodenum. If you look at it, the axis of your catheter is almost horizontal or perpendicular to the duodenal wall, in which case your gyre will usually go to the pancreatic duct. So what we need to do is, this catheter or the sphincterotomy should be parallel to the wall of the duodenum. So your approach should be from below upward, from right side of the field. And it should be parallel to the wall of the duodenum. And you should target to the 11 to 12 o'clock position. So before attempting cannulation, clean up and immobilize the duodenum, observe and analyze the papilla, and know the location. Sometimes the location of papilla may not be in the appropriate location, so you have to adjust your movements accordingly. And position and orientation of the cannulating device to the ampulla is the most important, crucial thing to adopt. And maneuvering and movement. I think most of the movement or maneuvering comes over time. I think you need to have at least 300, 400 ERCP done, then it will come, I would say, reflexly. But you should know, what movement to, use and when. Another thing is anatomy of the distalmost part of the CVD. Normally, we think that the CVD is very straight opening, but it is not like that. It is usually curved and S-shaped. And in order to mitigate this curved, anatomy, you have a mini maneuvering of scope. Unfortunately, the video is not opening. Otherwise, it was shown in this video. What you are required to do is flex the tip of your sphincterotomy, like here, which will intubate the vertical part of the CBD. And after doing that, you lift up your scope. Pull your scope little up. And then unflex your tip of the cannula. And ask your assistant to push the guide way. This way you will mitigate this S-shaped curve, and mostly the cannulation will be successful. So again, the prerequisite, shorten scope position, keep your ampulla always 11 to 12 o'clock position, and again, direction of your cannulating device, tip towards the 11 to 12 o'clock, aim from right to left and below upward. And the movement should be very gentle and coordinated. Now, as I already said, more than 80% of the time, the cannulation, an expert can cannulate without, employing the other alternative techniques. But there is often occasions where the cannulation is difficult. So ESG has defined the difficult cannulation, biliary cannulation, as more than 5 minutes after you visualize the ampulla spent in cannulation, or more than 5 contact attempts touching the ampulla, or if you have, put the guide wire inadvertently into the pancreas. So one of these criteria defines the difficult cannulation. Some have even given up to 10 minutes, but I think as a beginner, we should take and follow this, definition in our practice. So like shown here, there are different locations and shapes of papilla which make sometimes the cannulation extremely difficult. So how do you approach the difficult cannulation? There are different rescue techniques. One needs to master, I think. I would say before you start independently, doing your ERCP, you should, be versed with these techniques, especially pre-cut needle knife technique. There are different varieties of needle knife papillotomy. This may be freehand needle knife papillotomy, or you have put the stent in a small stent in the pancreatic duct and you give the incision over the stent, or sometimes transpancreatic sphincterotomy, especially when your papilla is very small and you have already put unintentionally put the guide wire into the papilla. You just cut cut the septum, also called septotomy. Septum, a small incision over the wire you have put inside the pancreatic duct. And double guide wire technique also there. And if all fail and there is indication, then either you refer patient to the high volume center, or you are expert in doing EUS guided cannulation. You can do anterograde cannulation techniques also. So since there is no video, so I will skip this slide. Okay, so no. Okay, so here you can see the over the stent sphincterotomy. In the next, okay, yeah, this was also a video, but here you can see the pre-cut fistulotomy. It's a very ideal papilla. It was just recently done, just yesterday only. In this, you can just give a small nick at around 11 to 12 o'clock position, and anyway, after giving the small nick, you can either come down incising or you can go up. So this is actually recommended by ESG as preferred method of pre-cut sphincterotomy. But for this, the papilla, especially the infundibulum, has to be bulged. So you can do it for the small papilla, type 2 papilla. So you open and then you cut, and then the cutting should be, in pre-cut cutting should be very stepwise. First you cut the mucosa and submucosa, then you have to take some time to flush it and to retract the lips. And once you do that, and then the inner muscle layer, sphincter will be visible. Usually, I normally give a small nick over the muscle at around 11 to 12 o'clock position. Most of the time, you will have good access into the CBD. So no video, I will skip again. This is also the fistulotomy. So nick given here and coming down, and then you open the bile duct. Okay, so this is also a video of transpancreatic sphincterotomy. After attempting for some time, our guide wire went to the pancreatic duct. So the papilla was a bit small, so we decided to do the transpancreatic sphincterotomy over the pancreatic guide wire. So what you do is bow your sphincterotomy a little bit and then make a small incision towards the 11 o'clock CBD side. By doing that, you are actually cutting the septum of the channel. And see, after that, we remove the sphincterotomy and then you cannulate the bile duct. Okay, double guide wire technique is, although the data does not support that much, but sometimes you can do this double guide wire technique. Most of the time, the difficulty is that this device will disturb you. But if you attempt 1 or 2 times, this is also okay, fine. So, how do we approach difficult biliary cannulation? So it depends on whether your wire is already inside the pancreatic duct or not. If pancreatic duct is not cannulated, you have tried 5 times or 5 to 10 minutes, then it is always, better to decide to, cut, to do the pre-cut. Because if you prolong the attempts, the more you prolong, the more chance of failure and the chance of developing post-ERCP pancreatitis is more. So the good thing is the data also supports that needle knife papillotomy in the earliest is the better technique. So you do directly needle knife papillotomy, or if you have already put the guide wire into the pancreatic duct, either you attempt 1 or 2 times double guideway technique, or you put a PD stent, 5 French PD stent, and do the over the stent needle knife papillotomy or transpancreatic papillotomy. If all these fail, then you have to decide whether to refer patient to high volume center or try another day. I would recommend try after 4 or 5 days if there is, if the procedure can be, prolonged, or if it is emergency situation like cholangitis, you can refer to high volume center also, or you can do EUS guided. So to summarize, the key to successful biliary cannulation, you should have patience, have your time to stabilize the duodenum. You should have always in a shortened scope position. Your scope, duodenoscope should be shortened position. At times, you might need, mid-long position. We often also try that, depending on the location of ampulla. But the standard is shortened duodenoscope position. Use Buscopan or Simethicon, liberally. And position and orientation of your cannulating device or ampulla is the most important, thing in achieving biliary cannulation. And you should always master these alternative techniques. And you should, of course, know your limitation, push your ego aside, and because you don't want to, make your patient develop, post-ERCP pancreatitis. Sometimes there is a stone in the CVD and you have successfully removed. Patient was asymptomatic, biochemically, clinically. Subsequently, after extracting, clearing the dog, patient developed severe pancreatitis, necrotic pancreatitis, which is not good. So you should also have a low threshold to refer to your patient to a high volume center. Or if you are expert in doing EUS guided alternative advanced technique, you can proceed with that. So thank you very much once again for the attention. Thank you.
Thank you, Dr. Ram. The next speaker.
I would like to welcome Dr. Mohan Kharka for his talk on techniques of biliary stone removal during ERCP. Please welcome him on the stage.
Dear respected delegates, a very good afternoon. Without delay, I'd like to present my topic, techniques of CVD stone removal during ERCP. There are various tools and techniques for CVD stone removal, especially for large stones or difficult stones, starting from CRE guided endoscopic large papillary balloon dilatation to crossing baskets, mechanical lithotripter, or cholangioscopy assisted lithotripsy, or ESWL. Why ERCP for CVD stone removal? Due to high risk of serious complications like obstructive jaundice, cholangitis, pancreatitis, ERCP is common method for CVD stone removal. Endoscopic sphincterotomy and stone extraction with balloon or basket catheters are successful in majority of cases, around 85 to 90%. However, conventional techniques are unsuccessful in 10 to 15% of cases with difficult CVD stones. Creating access to the biliary tree is important. ESG 2019 has recommended creating adequate exit for CVD stone removal as per papilla and CVD anatomy and size. Sphincterotomy alone or papillary balloon dilatation alone or combination of both are required. Endoscopic papillary balloon dilatation alone has lower technical success rate for stone clearance than sphincterotomy. At present, the use of papillary balloon dilatation alone is considered mainly in patients with coagulopathy or with altered anatomy if stones are less than 8 mm. The appropriate length of EST made according to papillary anatomy and stone size. In one randomized controlled trial, including 158 patients, clearance rate higher for balloon than basket. The other RCTs, however, including 184 patients, showed that efficacy and safety are similar for both balloon and basket. However, for a stone less than 6 mm was independently associated with failed stone removal within 10 minutes using a basket. A balloon catheter is more likely to complete stone extraction than basket for CVD stone 10 or less than 10 mm in a single session, that is 81 versus 17.8%. However, the risk of post-ERCP bleeding is higher in balloon group than basket. So this is the short clip video. Showing removal of multiple stones. Here, CRE balloon was used for endoscopic large balloon dilatation, and then balloon was introduced inside the CVD. Then balloon was inflated just above the distalmost stone according to the size of the CVD, and then it was dragged down softly and then removed with flip down technique. Flip down technique means moving big wheel forward or moving scope downward and right side or turning body slightly to the right. So mixture of these techniques are one just flip down technique is enough. So the other alternative for stone removal is basket. So putting basket inside CVD and then opening just above the stone and then slightly jiggling with the jiggling motion to and fro and side by side around the stone gets grasped, entrapped, and then slowly it is closed and then dragged down, and just by flip down technique it can be removed easily with the alignment of the CVD axis. So when stone is impacted at the ampulla, which is the most easier, I think. So just with NK pre-cut technique, we can give a small incision with electrocautery over the stone, over the roof for a few millimeters along 10 to 12 o'clock position. Then the stone is removed. ESG recommends endoscopic placement of a temporary plastic stent in patients with incomplete CVDS clearance. The success rate for stone removal after previous ERCP with biliary stenting has been reported to range from 44 to 96%. Covered metallic SEMS stents were efficacious in clearing CVD stones in 82% cases after about 8 weeks of stenting, as shown in large retrospective case series. What is difficult CVD stones? Any stone in the CVD or hepatic duct which cannot be removed by a single conventional ERCP session, that is biliary sphincterotomy and stone extraction with balloon or basket. Clearance of a difficult stone needs additional intervention techniques like endoscopic papillary large balloon dilatation, mechanical lithotripsy, cholangioscopy assisted EHL, or laser lithotripsy. So different society guidelines have given different characteristic for difficult biliary stones. However, for ESG has put 15 mm or more for the cutoff for large stone, and ASG has kept just 10 mm. And other characteristics are almost similar: 10 multiple stones or presence of stone intrahepatic or inside cystic duct, or impacted stone, or the shape, barrel shaped, eccentric shape or square shape, or bile duct anatomy, especially lower bile duct, which is narrower, small, angulated, or sigmoid shape, and previous failed ERCP are counted as difficult bile duct stone. So management of difficult biliary stones as per ESG 2019 has given a beautiful algorithm where divided into a non-difficult and difficult. For difficult, limited sphincterotomy plus endoscopic papillary large balloon dilatation with CRE is applied. If it is failed, then we have to go for mechanical lithotripsy or cholangioscopy guided lithotripsy or ESWL. If everything is failed, then putting a stent and trying ERCP for after 2 to 3 months is recommended, or considering referring to surgery if available, if other techniques are not available. Management of difficult CVD stone is already given in algorithm. ESG recommends limited EST combined with EPLBD as the first line of approach, and sphincterotomy plus large balloon dilatation reduces the need for mechanical lithotripsy by 30 to 50% in comparison with EST alone. In a systematic review, including 30 studies, the rate of overall adverse events was lower for EST plus EPLBD group in comparison to EST alone. So coming to techniques of EPLBD application, two-thirds of the CRE balloon is inserted inside the CVD and 1/3 outside the papilla. Then the diameter of inflated CRE balloon should not exceed maximum CVD diameter and can be up to 2 to 3 meters more than a lower CVD, provided there is no stricture in the lower CVD and no stone in between balloon and wall. The usual duration for balloon dilatation is approximately 30 to 60 seconds after disappearance of the waist. If the waist does not disappear, even after 75% of dilatation of the balloon, then a procedure should be stopped to avoid perforation. So there is a short video clip. So this is the ERCP done in Nobel 2 years back by me. There were around approximately 50 stones in the CVD. It was fully packed, and we did CRE balloon for large balloon dilatation for papilla, and then followed by balloon application, and with multiple attempts, we were able to clear all the CVD in single session. So, and then it became viral in social media also 2 years back. ESG recommends endoscopic mechanical lithotripsy for difficult stones when sphincterotomy plus large balloon dilatation has failed or inappropriate. The reported success rates range between 76% and 91%, and overall complications range from 3 to 34% with minimal mortality. Impacted stone size more than 30 mm, and stone to CVD diameter more than 1 were predictors of mechanical lithotripsy failure. ESG recommends the use of cholangiscope guided interluminal lithotripsy, electrohydraulic lithotripsy, or laser lithotripsy for effective and safe treatment of difficult CVD stone if conventional first-line approach fails. The type of cholangiscopy and lithotripsy should depend on local availability and expertise. So this is the short video clip again, how cholangiscopy is applied. So this I have drawn from one expert. So here laser lithotripsy has been applied to fragment large stones. So ESG suggests considering ESWL when conventional techniques failed or interluminal lithotripsy techniques are not available. It is overall 70 to 90% success rate. And surgical altered anatomy like Biliary 2 or UNY or Whipples, so we need to go alternative techniques. Balloon enteroscopy assisted ERCP is most common and more safe, but lately there are new technology going on. US guided ERCP through LAMPS called EDGE procedure or laparoscopic ERCP have shown higher success rate than enteroscopic guided ERCP. Thank you very much.
Thank you, Dr. Mohan, for your presentation. Now we'll call up the next speaker. He is Dr. Suresh Thapa, who is consultant gastroenterologist from Pokhara Academy of Health Sciences.
Good afternoon. Thank you, NAMS, for the opportunity. Today I'm going to talk on the endoscopic management of malignant biliary obstruction. Since it's a big topic, I think I'll only cover the treatment part rather than the investigation parts. So, talking about biliary obstructions, mainly there are benign strictures, indeterminate strictures, and malignant strictures. So we are not going to talk on benign or indeterminate strictures today. We are just going to talk about the management of malignant strictures. So this is the basic anatomy where the CBD is divided into supraduodenal portion, retroduodenal portion, and the pancreatic portion. But for all practical purposes in the management of biliary stricture, we just draw a line over here at the junction of the cystic duct to the common hepatic duct, and then divide the system into the hilar and then the distal biliary system. So the common causes of malignant biliary obstructions in the hilar region are cholangiocarcinoma, gallbladder cancer, and HCC, whereas the common causes in the distal obstruction are pancreatic cancer, ampullary cancer, and malignant nodes. So it's really always a challenge to differentiate between malignant and benign biliary strictures. So the findings, the lab findings suggestive of biliary strictures are raised alkaline phosphatase, total bilirubin, and raised CN99. And the imaging findings that are suggestive of malignancy are increased thickness of the bile duct wall to more than 5 mm, and an abrupt cut-off of and separation of biliary ductal system on cholangiograph, and the presence of regional lymphadenopathy. So for the imaging, I usually go for MRI, although CT and MRI are equivalent, but for the management plan, since we need MRCP, so I always go with MRI and MRCP instead of CT. So this is the MRI finding of biliary stricture, where there is an abrupt cutoff. This is a CT finding where, wherein there is hilar obstruction, and this is the US image where there is thickening of the CBD. Now, despite of discussing about endoscopic management, we as endoscopists should be aware that surgery, and that too with the R0 resection, is the only hope for cure. So all our focus should be to go for a multidisciplinary approach and target for R0 resection rather than to rush for endoscopic drainage without a plan. Because rushing to ERCP or endoscopic intervention leads to the contamination of the biliary system, which may then lead to the delay in the surgery. So as you can see, we should go for accurate staging whenever we suspect of malignant biliary obstruction, because survival depends on the success of resection. As you can see, the best survival rate is with R0 resection, and the success of resection obviously depends on accurate staging. So role of endoscopy is that it could be diagnostic, and as you can say, it's therapeutic, and it's almost always palliative, because by the time we diagnose malignant biliary obstruction, more than 70% are already inoperable. So main therapy is usually palliative, but in cases of early ampullary tumors without intraductal extension, then endoscopy may have some therapeutic role. So as you can see, the approach, when you suspect a person of having biliary stricture by history or by clinical finding or by abdominal ultrasound, we go for CT, and if we suspect that it is resectable, then we go for EUS, and if it is resectable, we go for surgery, and if it is unresectable, we go for palliation. So here, the main role of endoscopic management is in diagnostic and staging by EUS, and palliation by different endoscopic measures like ERCP or EUS. So major main modalities of diagnosis are EUS, ERCP, and cholangioscopy. So this is EUS picture showing distal ampullary growth with distal biliary stricture. So in these types of lesions, do we FNA or not? So this is a very important question, because if it is in the hilar region, if such lesions are there in the hilar region, and if there is no lymph node involvement, the patient should not be FNA'd, because there is a chance of tumor seeding. But whereas if the patient has distal stricture, like in this case, then FNA can be done, because even if there is tumor seeding through the duodenum, the patient is obviously going for the Whipple's as a therapeutic measure. So role of US in cholangiocarcinoma for primary tumors, there is technical challenge and we should not attempt it in the hilar region unless there is lymph node involvement because there is risk of tumor shedding. Whereas if there is lymph node, it's easy, safe, and very often the large, round lymph nodes are predictive of malignancies. And for intervention, US has a role in drainage and sometimes in fiducial placement for targeted radio or chemotherapy and in celiac plexus block or neurolysis. So role of ERCP is there for diagnostic purposes and for palliative purposes and also for ablative purposes. I'll come to them later. So the tissue acquisition is one of the major importance of ERCP, which could be done through either biliary brush or through the biliary biopsies. But the biliary cytology and biopsy have a very poor yield. As you can see, the sensitivity is only 42 and 56%, and the negative predictive value is also very low. So the limitations are that it has very difficult access, and there is limitation of 2D fluoroscopic targeting for biopsies. And there is inadequate tissue material because most of the cholangiocarcinomas are serous type, and if there is extrinsic cause of the obstruction like pancreatic cancer, there is no yield. So the choice between US FNA or ERCP is that for distal strictures, US FNA is better, and for hilar, the ERCP is better. However, both the findings though are not very acceptable. The yield is quite low. So for the distal, we choose US, and for the hilar, we choose ERCP and cytology, and if it doesn't yield anything, then we can go for single operator cholangioscopy. So this is the cholangioscopes. We are doing it at our center at Pokhara. So it is a 10 French instrument which pass through the duodenoscope. It has 4 directions for steering, and it has 1.2 mm accessory channel. And however, its drawback is that it has a single use, and it's very easy to use. It's just a play and plug setup. So I don't go into this. So what do we do with the resectable malignant biliary obstructions? Only about 30% of them are resectable at the time of diagnosis. So do we go for preoperative stenting in asymptomatic patients? It's highly controversial. However, the definitive indications are for the patients with significant debilitating symptoms and the patients who are planned for neoadjuvant chemotherapy, and for patients who are planned for major hepatic resection when the future remnant liver is predicted to be less than 30%. And most of the surgeons, they prefer bilirubin to be below 10 or 15 before going for surgery. And for them, for resectable cases, we opt for plastic or fully covered metallic stent. And so the choice between plastic or metal stents for inoperable distal obstruction is, I'll make it shorter. So the patency is better for, this is the Dodge study. The patency is also better for metallic stent, and the cost effectiveness is also similar for both. So these days, stents are advised for all, but we should take it with a pinch of salt because of the cost factor. The plastic stents are far cheaper in our part of the world. So for unresectable obstructions, we go for the major modes of biliary drainage are ERCP, US guided drainage, and percutaneous drainage. So what we should be knowing before performing endoscopic biliary drainage are the bismuth classification and the atrophic lobe, the involvement of the veins, and about abnormal anatomy. So this is, as we know, is the bismuth classification. And so the target for all the drains should be always at least more than 50% of the liver volume, because this study from France showed that the effectiveness of drainage and median survival is better with drainage of more than 50% of the system, and the risk of cholangitis is low. For inoperable cases, which stent should be put, plastic or metal? So this is a study from Japan where the SEMS fared far better than the plastic stents. So we go for metal stents, and we usually use covered metal stents. We usually use uncovered metal stents because covered metal stents may inadvertently obstruct the intrahepatic side branches in hilar strictures. So how many stents should be used? And should we go for unilateral or bilateral drainage? So the study suggests that this is from, again, the Korean study. This shows that the bilateral drainage has better survival benefit and also the stent patency rate. So bilateral stenting, or we should drain at least 50% of the liver volume. So how many stents should be used? So this slide I had taken from Reddy sir's presentation. So if we have bismuth 1, bismuth 2, and bismuth 3B, then single stent is enough. But for bismuth 3A and 4, we go for bilateral stenting. So the methods could be either side-by-side stent or stent in stent. I usually go for side-by-side stent. But for side-by-side stent, the CBD diameter should be enough. It should be wide enough to accommodate 2 or more stents. So if it is not enough, then we can always go for stent in stent or Y method. So do we go for endoscopy or PTBD? It's also quite simple. For type 1 and type 2, we obviously try for endoscopic drainage. But for type 3, we consult with our IR friends and decide accordingly. But for type 4, PTBD is always the choice because it's really difficult for endoscopic cannulation. So for the other method is US biliary drainage. If you cannot access the biliary system, then we can always go for US biliary system, which could either be transgastric, which is called US hepaticogastrostomy, or transduodenal, which is US choledochoduodenostomy, or we can always go for Rendivo. So this is the US biliary drainage, that is hepaticogastrostomy, and this is the drainage. The other is choledochoduodenostomy, US guided choledochoduodenostomy. And last, where we can also go for adjunctive endoscopic therapies. Among them, radiofrequency ablation is cheaper and highly efficacious. It uses thermal energy and it is to ablate the tumor, and it is mainly used for intraductal cholangiocarcinomas. The other methods of adjunctive endoscopic therapy are photodynamic therapy, drug-eluting stents, and intraductal radiotherapy. And to conclude, more than 70% of biliary strictures are inoperable at the time of diagnosis. So palliation requires multidisciplinary approach. So we should always discuss with our surgical friends and interventional radiology friends. And before endoscopic intervention, a proper planning should be done so that the target should always be R0 resection. Thank you.
Thank you, Dr. Suresh. I request all our speakers to come forward. Dr. Ram, Dr. Mohan Khadka, and Dr. Suresh Thapa. And the floor is open for the question answer session. Only the few questions we have, due to the time constraint, few questions are allowed. Any question from the floor? If there is no questions, we move forward.
I hope there are no more questions. Thank you so much, chairpersons and the speakers of this session for the wonderful presentation. Now I request the chairperson of the session to provide token of love to our esteemed speakers. May I now request Dr. Ramila Shrestha to provide token of love to Dr. Ram Gurung. Dr. Prasan Sharma to provide token of love to Dr. Mohan Khadka. Dr. Rajesh Pandey to provide token of love to Dr. Suresh Thapa.
Now moving on to our next session, that is endoscopic ultrasound session. I'd like to request the chairpersons, Dr. Kiran Khanal, Dr. Srijan Man Pradhan, Dr. Divas Kharka, and Dr. Sajid Karki to chair the session.
Next session is all about endoscopic ultrasound session. First speaker is Dr. Sandeep Raj Kumar. He is working in Norwich Hospital. His topic is biliary, basic biliopancreatic anatomy by endoscopic ultrasound. I'd like to welcome him in this presentation. Thank you.
Thank you very much. Thank you very much, Gastro Update, and Dr. Mukesh and team for providing me an opportunity to speak in basic pancreatobiliary anatomy in endoscopic ultrasound. I'll also be talking a little bit about the applied anatomy as well. So we all know endoscopic ultrasound, basically an ultrasound probe which is attached to the endoscope. It was conceptualized in 1960s. It got acceptance in 1970s to 80s, started in Japan. In early 2000, it started in India. Better late than never, we started US service for the first time in Nepal in 2014 in Norwich International Hospital. At the time when the US was there, nobody knew, we were not trained for endoscopic ultrasound in Norway, in Nepal. So I had an opportunity, Dr. Madhu Ghimire sent me to Professor Malay Sharma in Jaswantrai Specialty Hospital. I stayed with him for 2 weeks, and we did a lot of cases, diagnostic and as well as therapeutic. Yes, and also in BLK Hospital, I got an opportunity with Professor Yogesh Batra, and I stayed with him for a lot of therapeutic endoscopies. Also in Professor Dong Lee in Korea, in Yonsei University, I got an opportunity. He's regarded as one of the best ERCPs in the world, and he has a team of endoscopic ultrasound specialists there as well. So I had an opportunity to work there, the heaven for that. And yes, Professor Anil Arora is here. Most of the gastroenterologists of Nepal, he has been a mentor to all of us as well. So just coming back to the topic, radial versus linear, we all know the radial is the 360-degree visualization scope, forward viewing, easier to use. But for diagnostic and FNA therapeutic purposes, you will be requiring linear. Linear can do diagnosis and therapeutic both. You have to have a little bit of practice using a linear scope. So if you have an endoscope ultrasound, you're going to buy a new one, I think you should buy a linear scope, because these scopes are very, very expensive, and buying both would be very costly to the hospital. So if you talk about the pancreas, it's just behind, behind the stomach, just posterior to the stomach. The small bowel is wrapping around it. So this location is so suitable, especially for the pancreatic disorders. The US is very easy. You can see the head, neck, body, tail, and the uncinate process of the pancreas, which is accessible. And most of the time, when there is the problem is in the tail of the pancreas, the patients do come late, and sometimes the CT and MRI have difficulty in diagnosing the small lesions. That is what it's used for. The diagnostic yield with smaller lesions and US FNA can be done, and that helps us as an endoscopist. And of course, the CBD and pancreas, it's one of the wonders to find out the lesions and everything. And we know that pancreas is a very vascular organ. You had a lot of blood supply, vascular drainage, and major vessels encasement also can be found out, which decides the resectability for the surgeons. It does help. It does complement CT and MRI for the same. Okay, and US, of course, our speakers also talked about the rescue procedures where ERCP sometimes is very difficult due to the anatomy. So EUS is in the rescue, the rendezvous procedures can be done to cannulate the bile. I think it's also going to replace one day, the ERCP will be replaced by US in cannulating the bile duct. So here are the different stations of EUS. I use linear scope only, and so you can go from the G junction, stomach, the gastric body, to the antrum, D1, D2, sometimes D3 are these stations where you visualize different structures from different angles. So the best thing is that you can even do from the D2 can come back, or you can go from the esophagus. I prefer going from the esophagus. My first thing is I'll go for the aorta. It's very easy to find out the aorta in the thoracic aorta towards the abdominal aorta in the G junction. You can find out the celiac artery and the SMA, the branches. And you can also see the crura of the diaphragm there. And this is a very important location. If you get lost while doing an EUS, you have to come back and you have to find out this position as well. You know, it'll be very easy. So once you find out the celiac artery, you can follow it to the splenic artery, the branch. And besides the splenic artery, just adjacent to is the splenic vein. And you can see the pancreas just above the splenic artery and vein. And once you find out the splenic vein, you can just do a counterclockwise rotation, you know, the splenic vein. Just do a counterclockwise rotation slowly, then you can go to the portal vein confluence. Once you reach the portal vein confluence, then you can see the CBD, the proximal CBD from there as well. This is in the gastric body. So you come back to the position, again the SV and SA, the splenic artery and splenic vein position again. So after that, you can do the clockwise rotation, pulling a little bit. You can now visualize the left kidney, you can visualize the spleen, and sometimes you can see the seagull sign. That's for the adrenals as well. Sometimes adrenal adenoma can also be visualized. And between the kidney and the left kidney and the spleen, there you can see the tail of the pancreas. Gallbladder, very well visualized from the antrum, sometimes in the D1. So you can see it's a beautiful visualization of the gallbladder. The thickness, even the sludge can be visualized very easily. The patients are usually in the fasting state. So the gallbladder is very distended and easily visualized. And now I'm talking about the D1. I think D1 is the very important station of the endoscopic ultrasound. Why? Because most of the patients that are referred to us are usually with obstructive jaundice, and most of the patient with obstructive jaundice has lesion in the head of the pancreas, either or they have CBD stones. So once you go to for D1, you can visualize the parallel CBD, the main pancreatic duct. Once you visualize these two together, they are called the stack sign. And once the stack sign is there, that means that you are in the proper head of the pancreas position. So you can take biopsies, FNA, whatsoever, and this is a very crucial location as well. So you can see the CBD with a stone. Usually that's what we see with the shadowing. That's very easily identifiable. Do a ERCP, remove the stones, patient is fine. Sometimes there you can see the CBD, dilated CBD without any shadowing, and this was a 14-year-old boy with obstructive jaundice who had calcified dead ascaris, you know, and was removed by ERCP. Sometimes, you know, young females, they do have issues, soft stones, and the liver functions are okay, the ultrasound is okay, the pain abdomen doesn't subside. So the EUS does really help in this kind of patients, where you can see the small stones, 3 millimeter or 4 millimeter stones that are stuck in the CBD without undilated CBD, and then you can remove it with ERCP easily. Cystic lesion of the pancreas, we already been discussed. Cystic lesions of the pancreas is sometimes a difficult job for the gastroenterologist to find out if the lesion is precancerous, if the lesion is just the pseudocyst. So sometimes I do, the location, the size, the location, the mucinous content is very important. And also another thing is the communication with the ducts, as well as you can just suck dry the small cysts, and then you can do its amylase and CA levels, that you can sometimes differentiate between the pre-malignant and the pseudocyst as well. Lymph nodes, yes, you can do all the lymphadenopathies. It can be abdominal lymphadenopathies. Sometimes you can distinguish that from pancreatic, suppose cancers, and even tuberculosis. It's also the size and the shape, necrosis, all that matters there as well. And we have really performed suspected cancer, pancreatic cancer patients. We have found tuberculosis in those patients as well. So you have to be very careful before diagnosing them as pancreatic cancers. And sometimes these females, it's not very uncommon. Young females do have this multiple septated lesions with variegated appearance. These are called SPEN, and we have referred them to surgery. Sometimes you also can find out the pancreatic nets, is shown in the other picture. Differentiating between pancreatic cancer and sometimes chronic pancreatitis is also very useful, and US elastography is also one of the very helpful techniques that you can do. The blue one shows that it's a hard lesion, the red one shows it's a small, soft lesion. So this can differentiate between the chronic pancreatitis patient with a malignancy transformation, and that also it's with a very good specificity. Needles, yes, I'm not going to talk about the needles, but this FNA, FNB, we have a lot of needles that upcoming Chinese brands are also building up with very extensive, needles that are very useful these days. And once Professor Chang, he was also one of the best endoscopic ultrasonologists around the globe from US, Dr. Neeraj Joshi, and I had a chance to meet him in Human Organ Transplant Center. And this was the 2016 probably, this was the FNA sample that he took out. It was so specially, he took out the samples. The quantity was so great, and this is the time he taught us how to take samples, adequate samples as well. Celiac plexus neurolysis, how many of you do it, I don't know, but I have been regularly doing this procedure, especially for patients with pancreatic cancers. Those who cannot have intolerable to pain despite medication, especially on 0.10 analgesics, and sometimes with chronic pancreatitis patients as well. And you can see the celiac artery just above it. The celiac plexus can be visualized, and you can do the pure alcohol, 100% alcohol injection, at least 10 ml alcohol injection, really does good for the patients for quality of life. So now the gastrostomy, US gastrostomy, we have been doing it since 2014. Multiple patients we have done. I think we have got another speaker we'll be talking about. And recently we also have done the US guided coil embolization. Dr. Shekhar has joined us as a team member in Norway Hospital. So we have done around 4 to 5 cases successfully, and I hope we'll be doing this regularly. Endoscopic ultrasound, this is basically offers detailed and accurate visualization of pancreaticobiliary anatomy in high resolutions. You can see the bile ducts, pancreatic ducts, very crucial in diagnostic pancreatic cancers, and also FNA can be done. So it has got a lot of possibility for pancreaticobiliary pathology. So I think it's a must that gastroenterology department should have an endoscopic ultrasound. One endoscopic ultrasound for every department should be there. Thank you very much.
Thank you, Dr. Sandeep, for the talk. For our next session, I would like to call Dr. Shekhar Paudil, who is associated with Norway International Hospital. He will be giving us talk on US guided coil injection for gastric varices.
Good afternoon, everyone. I will be talking on the endoscopic management, endoscopic ultrasound guided therapy for the management of gastric varices. So, as you know, the gastric varices consist around 20% of all gastroesophageal junction varices bleed. Despite the frequency of the bleed is low, the gastric varices bleed is associated with increased risks of uncontrolled bleeding, rebleeding, more transfusion requirement, and the higher mortality. Current option what we have is the cyanoclide polymer, retrograde transvenous obliteration, that is most commonly we use BRTO, TIPS, all the procedures having their own set of complications and difficulties. One thing to know that is important is, unlike esophageal barriers, which have direct relation with the portal pressure, more the portal pressure, more the chance of the esophageal variceal bleed will be there. But in gastric varices, there can be normal or even lower pressure, portal pressure. So targeting the portal pressure, especially with the non-selective beta blockers or TIPS, can be insufficient in treating or preventing the gastric variceal bleeding. So endoscopic ultrasound guided therapy has came as the emerging endoscopic modality, particularly in compared with the traditional direct endoscopic glue therapy. So regarding the classification, over the last 20 years, the Sarin classification is the most commonly used classification worldwide. And regarding the apparent and efferent supply of the varices, the GOV1 is closely related to the esophageal varices. That is, efferent supply is most commonly by the left gastric vein, while efferent is by the esophagus venous system. While in the GOV2 and IGV1, the efferent supply is mostly by short and posterior gastric vein, while that of the efferent supply is by the splenorenal shunt. But especially for the US guided therapy of the gastric varices, ARCOA classification can be more helpful. Here we classify the varices into type 1, type 2 based upon the number of feeder vessels. So if there is only one feeder vessel, it is type 1, while if there are multiple feeder vessels, it will be type 2. So for the coil embolization purpose, can either go through the, we can directly embolize the varix proper or to the feeder vessels, either through the transesophageal route or through the transgastric route. For the preparation, we usually need the curvilinear US scope, 19 gauge USFN is most commonly used for the larger size varix, and we use multiple syringe filled with distilled water. Coils, the most commonly used coils are 16 to 20 millimeter. It's most of the time we do only for large varix. Cyanoclide glue and lipidol, if available, can be used to avoid the early polymerization inside the needle. So we can do it either in deep sedation or general anesthesia. The scope is positioned at the G junction, where we visualize the varix as cluster of anechoic channels located within the soft mucosa. We can install 100 to 200 ml of fluid in the gastric fundus to make the varix floating. And after the visualization of the tip of the varix, we can put single or multiple coils according to the size of the varix. So most of the time, the size of the coil you use is around 20 to 40%, 20-30% larger than the size of the varix. So this is one of the recent patient. He had both large esophageal varix as well as large gastric varix. So the procedure was done in the same setting for him. So after we put the multiple coils under the US guidance, we can inject the glue either with the US scope, same scope, or with the gastroscope. After the glue injection, we promptly withdraw the needle within the sheath, push the sheath out of the echoendoscope, and then remove the entire assembly into the scope. And we can reintroduce the echoendoscope and check the Doppler flow within the varix. So we can also use fluoroscope simultaneously for monitoring the deploying of the coils during the procedure. So another method for coil embolization is the feeder vessel embolization. But main issue is with the feeder vessel embolization is the identifying the feeder vessel can be challenging. Occasionally multiple feeder vessel can be observed. So and the main benefit of embolizing the feeder vessel is we need the less number of coils and glue, and there is the benefits of less number of re-intervention. Regarding precaution and follow-ups, US needles should be visible throughout the procedure time. We should avoid the forceful jab to immobilize the whole varix in the single puncture, because multiple puncture can lead to the risks of the glue exclusion after doing the procedure. And surgeon and IR should be involved if torrential bleed or needle impaction occurred. But most of the time it will be only minor bleed and can be managed with the repeat coil or glue embolization. Follow-up assessment can be done at 4 weeks, 3 months, and every 6 months after the gastroscopy. And US intervention based can be repeated based upon the Doppler flow. These are the same patient. It is after 2 weeks of the therapy. On gastroscopy, there is the complete solidification of the varix with no soft part. And in US, there is no Doppler flow. So regarding comparison with the US coil and glue therapy with endoscopic glue injection, in one of the study where they compared the US coil plus glue with endoscopic glue, what they have found that compared to the endoscopic cyanocolate cohort, US cyanocolate plus glue arm showed significantly lower number of the anesthesia requirement, lower subsequent bleeding episode, and low intervention rates. Similarly, in this study, where they use US-guided coil plus glue therapy in both primary cases with large varix more than 10 millimeter, rescue case, acute bleeding case, or secondary prophylaxis case, where they had shown that though technical success rate and glue volume was, success rate was almost similar, the amount of glue volume required, reintervention rate, time to intervention rate, and survival time was significantly better in the US coil embolization group than in the US guided cyanocolate injection. Similarly, in this study, what they did is they classified the patient into 3 groups. That is US guided therapy, all 3 groups with US guided therapy, US cyanocolate alone, US with coil alone, and US cyanocolate plus coil therapy. What they found was the clinical success rate was and rate of adverse event, rate of reintervention rate, and rate of rebleeding was significantly better in the US coil plus glue therapy. Similarly, it is one of the studies from India where they actually did the US per coil therapy in the sick patient with the higher MELT and CTP score. Even in those group of patients, the US guided coil plus glue therapy shows similarly lower number of the session required, in average lower amount of the glue injection, and low risks of the rebleeding. Regarding the comparison with the IR guided therapy, that is most commonly BRTO, in this retrospective study, they compared the US with BRTO. What they found was the US group and BRT group has similar rate of 6 weeks mortality, and 1 year all cause of rebleeding, 1 year mortality rate in both groups were similar. But in this study, it is one of the abstract published in ASLD. So what they did is they compared the US guided coiling with US guided glue therapy along with the IR therapy, that is BRTO and TIPS. What they found was the US guided coil had very low rate of, significantly low rate of reintervention as compared to endoscopic cyanocolate therapy and IR therapies, both BRTO and TIPS. US guided coil demonstrated significantly low rate of readmission at 6 months compared to 35% at endoscopic cyanocolate therapy and 25% at IR. So this is another study by Dr. Jayant Samanta and al. On last GDW session, where they actually compared the US and BRTO from 3 centers from India and Italy. What they found was, although the technical success rate and obliteration rate was similar in both the groups, but the rate of adverse event, especially worsening ascites and sepsis and esophageal worsening was significantly lower in the US guided therapy. So regarding the cost effectiveness and choice of therapy, what we should know that if patient has undergone US plus coil and glue therapy, you can discharge the patient on the same therapy if it is for primary and secondary case prophylaxis therapy. Average cost of the therapy at our center is around 1 lakh. Even in one of the study from the US, what they did is they compared the cost of endoscopic cyanocrylate therapy and US guided therapy. What they found was, though single time procedure cost was lower in the endoscopic cyanocrylate therapy, but total cost of treatment, considering the bleed, readmission and treatment rate, it was significantly lower in the US guided therapy. Similarly, this is the study from Medanta, where the cost of procedure is around 850 versus 326.25 in the US versus the IR therapy. And they use this therapy for all kind of patients, that is, to prevent, treat, and secondary prophylaxis. The technical success rate was 100% and clinical success rate was 90% after the single procedure. So, regarding the current guidelines on the US management of the gastric varices, there is no clear recommendation like that of the esophageal varices for the management of gastric varices. Most guidelines still prefers the non-selective beta blockers for primary prophylaxis of gastric varices, endoscopic therapy for acutely bleeding varices, or BRT or TIPS as the alternative rescue. US therapy, especially by Bivinum 7, has still kept on the research agenda. The issue for this unclarity in the guidelines is, still we do not have uniformity in the study on the choice of the targeted vessels, that is either intramural or purporter veins, and types and number of coils to be used. There are still no large multicenter study on efficacy, safety and durability of that therapy. No good RCT comparing with this therapy, particularly IR-based therapy, and US guided therapy for, should be used for primary prophylaxis, acutely bleeding or secondary prophylaxis is still not clear. So, coming to summary, unlike the management of esophageal pharynx, which is relatively straightforward and supported by wealth of clinical studies, gastric varices pose the relatively scarcity of supporting evidence to guide the best practice. Still, US-guided treatment of gastric varices poses a novel technique with potential to significantly improve the management of gastric varices. US-guided guidance of therapy allows us for clear visualization and precise targeting of the varices and feeder vessels, even in the setting of the active bleeding. We can directly visualize the occlusion of varix in the real time in the Doppler. US and especially US coil plus glue have theoretical benefits of synergistic action and reduced glue amount and embolization risk. So it is better to go for US coil plus glue rather than US coil only or glue only. So further studies are needed to demonstrate the benefits and superiority over the conventional medical and radiological therapies as by recommendation of the current guidelines. Thank you.
Thank you, Dr. Sekhar. For the next talk, I'd like to call Dr. Mukesh Ranjan. He works as an associate professor at Chittoor Medical College, and he'll be giving a talk on EUS guided cystogastrostomy. Dr. Mukesh.
Namaste everyone. First of all, I would like to thank the organizing team for inviting me here. This is a wonderful program that runs every year. So where I shall be talking about EUS cystogastrostomy for another 8 or 10 minutes. So basically, we know the management of peripancreatic fluid collection has evolved over time. The concept has changed, the methods have changed. So we are no longer considering the rule of 6 for treatment, and now we have moved from surgery to endoscopic management, because endoscopic management does offer a benefit over surgical management. So talking about the indications, well, any collection that causes symptoms like pain, abdomen, early satiety, or complications like infection, bleeding, or rupture, or obstruction of the nearby organ, then they should be drained. Now for endoscopic ultrasound-guided intervention, if these features are there and the collection are nearby the stomach or duodenal wall, then they fit for the indication for EUS cystogastrostomy. Now, before you go for that, you have to have certain, a checklist that has to be there. Like you have to have a baseline cross-sectional imaging, preferably MRI, in order to look for any kind of debris which is present there. Many prefer doing CT scan as well. Anything available to you is fine, because you will have US to assess for the debris and all. Then you have to have a multidisciplinary team backup, where you have to have your GI surgeons, colleague, intervention radiologist, and anesthesiologist, because these are the procedures that are bound to lead to complication some point of time in your career. And of course, you need to have fluoroscopy services as well. So there are basically 4 methods of US cystogastomy. The first one is conventional multi-step procedure, where we put plastic stents. And for this talk, I will restrict myself to the plastic stent deployment, because metal stent deployment and everything cannot be included in this talk. So the other methods are, application of lamps without electrocautery over a guide wire, then lamps with electrocautery over a guide wire or without a guide wire, that hot axios or spaxes that we have these days. What difference does it make if you use lamps over plastic? Well, there are studies. There are RCTs, including 13 studies, over 1,500 patients, and that do suggest that technical success-wise, plastic stent deployment is equally successful compared to metal stent deployment. Similarly, clinical success-wise, there is very little to separate them. But if you look at adverse events, the adverse event seems to be slightly favorable with use of lamps, and that was because of a favorable adverse event profile in cases of wall-depth necrosis. But in pseudocyst, applying both plastic stents or let's say lamps does not have much of difference. So how do we choose which procedure to carry on? So basically, there are a lot of logistic that comes into play. So if I am doing my first or second procedure, then I will obviously like to use hot access, because this is a single-step procedure. If your patient is sick, and you want to reduce the procedure time, then obviously go with lamps. Similarly, for wall-depth necrosis, and you suspect that there is going to be need for necrosectomy, then obviously you will like to place lamps in cases. But in pseudocyst, you can choose any of the modalities. But in cases of disconnected pancreatic duct, where you want to have let's say a stent for indefinite time, or in cases of pseudoaneurysm that is existing in the vicinity of the cyst, where you suspect or fear that lamps can erode into that, leading to bleeding, or a patient who you think may not be coming back to you for follow-up because of financial reason or something else, or if cost is the issue, then you will obviously choose to put plastic stent in these cases. So the tools required, obviously, first and foremost, a linear echo-endoscope probe with a working channel that as good as therapeutic scopes. Then you will require 19G US FNA needle, 035 guide wire, a 6 French or even 8 French system would do, then CRE balloon and stents. So plastic or lamps, whichever you want to use. All of your patients, before going to the procedure, they should be on broad-spectrum antibiotic prophylaxis, at least for 5 days after procedures. They should be fasting overnight. You have to stop any blood thinners that is going on as per the protocol. You should be doing this procedure in general anesthesia. Your patient should be in left lateral position and should be intubated, because once you dilate the tract, there is going to be a lot of fluid coming into the fundus that can result in aspiration, which is one thing that you want to avoid doing this procedure. So intubation should be, if you suspect there is a large cyst, then intubation should be a protocol. There are multiple steps for US cystogastomy. We will see one by one. First step is the US examination of the cyst. This is a very important step, because, this gives you an opportunity to look the cyst up close, right? So where you can see the thickness of the cyst wall, you can see whether any vessels are there in the trajectory of the needle or not, or even US can help you differentiate between cystic neoplasm or as collection. So while looking for vessels in the trajectory of needle, you should let loose your big wheel, because sometimes if you are taking big wheel down, then the probe might be pressing a vessel that is not visible on Doppler. Then the next step is puncturing the cyst wall. For this, we use 19G US needle, FNA needle, and while doing so, it is advisable that you stay as perpendicular as possible, because you should be avoiding any tangential puncture, because this will lead to a lot of complication, and trouble while performing the subsequent steps. And after puncture, it is mandatory that you aspirate some amount of fluid because you want to see whether there is blood inside or not. If you find blood by any chance, then you should stop your procedure because patient might be having a pseudoaneurysm or a ruptured vessel inside the cyst. So then you want to introduce a guide wire along this needle. So once you pass a guide wire, you should make at least 2 to 3 loops inside the cyst wall so that even if you lose the access to wire, sometimes you have enough of length of wire inside this cyst. And you should always keep the wire visible in the echo endoscope view because the wire gives you a good idea of the puncture sites. And you should avoid any kind of loop formation between the echo endoscope tip and the wall of stomach. Because if there's a loop formation, the subsequent steps of applying, cautery and everything becomes very difficult. So your scope should be as stable as possible. You should visualize the guide wire. Then you have to change the needle, take out the needle, put a cystotome, and then you should introduce the cystotome inside the cyst. So while doing so, we use Endocut cautery setup that we use for sphincterotomy or needle knife pre-cut. Then it is very important that your scope is stable, your wire is visible in the echosonographic view, and once you press, before you press the cystotome against the wall, you should paddle up the cautery system. And the pressure you apply over the cystosome should be very gentle and a constant pressure, because if you apply jerk or a pressure that is well enough to overwhelm the guide wire, then you may be entering a false track that can lead to complications. Then you have to dilate the track. So for that we use CRE balloon, and you should ensure that the waste is no longer there. That means if the waste is no longer there and the balloon is visible cylindrically, then you have done a good job. And that can be confirmed that can also be confirmed in the echo endoscope view as well. So it is important that you visualize this finding under fluoroscopy as well as under endosonography. And while dilating, once you deflate the balloon, then there will be a lot of fluid coming into the stomach and should start doing suction at the same time, because you do not want to have a lot of fluid there that will hinder your vision as well in the subsequent procedure. So once you have dilated the tract, then the last step is introduction of the stents. So here I will talking about plastic stents. So if you are going to place a 10 French stent, then you should always use OSS stent inducer system, because 10 French stents are very stiff. They can coil even over a 035 guide wire. So you should use OSS stent inducer system. And if you want to place 2 stents, now then you have to have access of 2 wires inside the cyst. Many people do prefer deploying first stent and then only trying to getting access into the cyst by another guide wire. That becomes very difficult, because once you place a stent, the cyst will decompress and the angle of entry changes a lot. So it becomes very difficult for you to regain the access after placing a single stent. So what you can do is you can introduce 2 wire. Either you can use a stent pusher to introduce another wire, or you can use this cytobrush sheath and apply another wire as we do in ERCP. So, and while deploying a stent, it has to, your force of, your direction of force should be different than in ERCP. So your big wheel should be away and your elevator should be loose, and you should slightly withdraw the scope and then try to push the catheter stent, so that the force of direction is not along the entry point and you do not end up deploying the entire stent inside the cyst. So half of your cyst should be inside the stomach. What about single or double stent? So there will be debate on this, but there are studies that suggest that even a single stent can be equally efficacious in draining pseudocysts, especially if there is no debris. So I like us who are in earlier stages of learning curve, we can apply a single stent and do the same work. But if you have done a lot of cases and feel comfortable, then double stent can be deployed. So when do you want to remove the stents? Well, if you have used lamps in wall-off necrosis, then you should repeat imaging in 3 to 4 weeks. If the size has reduced to less than 3 centimeters, then take it out. Otherwise, you can follow it up. If you have used lamps in pseudocyst, then pseudocyst will tend to get drained earlier. So you can order a CT scan in a couple of weeks, and if the cyst has resolved, then you can take it out. But in plastic stent, it should be there for at least 6 to 8 weeks. So you should follow up at 6 to 8 weeks and see if there is resolution of the collection, then you can take it out. There are certain complications associated with this process, so we should be vigilant. That's why you require a lot of multidisciplinary backup. So there, the peripostural complication can be technical failure, mal-deployment of stents, perforation, bleeding, or air embolism or injury to the adjacent organs. Similarly, late complications can be bleeding, buried stent, chronic pancreatitis, and even biliary obstruction at times. I would wind up in another 1 minute or so. So this is a male patient in his late 30s that presented to us a few weeks back, and this was the procedure we did a couple of days back only. You can see there is a big collection, and which is lobulated and compressing the stomach. So, okay, so we have localized the cyst, measure the distance that is less than 1 centimeter. Then we are looking for any vessel. There is a vessel that seems to be in the trajectory of the needle. So we go to other side, and we have already punctured the cyst and aspirating fluid. It is important because I want to see if there is blood inside or not. So this should be in every procedure. This should be done after puncturing the cyst. So please ignore my nose there. So there is guide wire going. We are inserting the guide wire through the needle, and we ensure that we made 2 to 3 loops inside the cyst wall. After that, we did we had passed cystotomy, and following that, this is the CRE. What we have done is dilated it fully, and the tract seems to be well dilated, which is confirmed on fluoroscopy as well. Finally, we put a single 10-frame pictorial stent. This is the OSS system, and you can see the stent coming. This is the stent, and you just can see the first marking just appearing here in the video. Yeah, this is the first marking. Sometimes you can mark the stent in between as well. This is the intermediate marking. And once I see the last marking, then I should stop applying pressure. I should put away my big wheel, let loose my elevator, then slightly withdraw the scope, and then only I insert the remaining portion, which will get deployed in the stomach as this has been done. So this brings me to the last slide. If there is no symptom, we do not drain any kind of collections. Endoscopic transmural drainage and use of EOS has been the standard of treatment these days. Plastic stents can be a very good alternative to metal stents if cost issues and technicality is the issue. For a better success rate, it is important to choose the right case, choose the right accessories, and also a dry run. That means you have to rehearse with your staff, with your residents, because not all the centers are provided with a good technician. So this is very important. We do not lose patients, because wire may get out of your focus sometimes, but you can always achieve the sonographic view of the wire. And obviously, we have to be ready for any kind of adverse event that comes. It is important to identify the adverse event immediately so that you end up saving the patient's lives. Thank you so much.
Thank you, Dr. Mukesh. Since we are running short of time, we won't be taking any questions that can be discussed within tea break. Now we declare closure of this session.
Thank you, speakers, for this session. Now I'd like to request the chairpersons and speakers to come on stage and request the chairpersons to provide token of love and certificate to our speakers. I would like to request Dr. Divas Khadka to provide token of love and certificate to Dr. Sandip Raj Kumar. Dr. Srijan Man Pradhan to Dr. Shekhar Paudel. Dr. Kiran Khanal to Dr. Mukesh Ranjan. Now I'd like to request everyone to proceed for a short tea break of 10 minutes.
Am I audible?
Hello, sir.
Hello, am I audible? Hello? Hello?
Sir, you are audible, sir.
Perfect, perfect, yeah.
Okay. Sir, we'll be starting in 2 minutes.
Sure.
Okay, sir.
Welcome back everyone after a short tea break. Now we'll be continuing our session. The next session is the International Speaker Session 2. To chair the session, I would like to request the chairperson, Dr. Bhupendra Kumar Basnet, Dr. Pradeep Vaidya, Dr. Khushbu Priya Mishra, Dr. Nikesh Mani Shrestha.
सुरु गरौँ? Now, welcome back after tea break. Good afternoon to all. Now we are going to start the next session. It's an international speaker session. We have 3 renowned international speakers in this session. Govinda Makharia, Dr. Anil Arora, and Dr. Muhammad Saiful Islam. Now we are going to take a online from Zoom talk from Dr. Govinda Makharia. He was supposed to come, but some technically health issue, he could not attend this program in person, but he's online. I would like to thank Dr. Makharia. Your topic is dietary intervention in inflammatory bowel disease.
Thank you, Dr. Bhupendra and the scientific committee of your chapter. Thank you so very much for invitation. First of all, my apology that I could not come personally because I got injury to my ankle. It's a minor problem, should heal in 1 to 2 weeks' time. So taking on to the topic, which is IBD and what is dietary intervention. We all know. I hope I'm audible to everyone. Hello.
Yeah, audible, sir. You can continue.
Perfect. So the topic is dietary intervention in inflammatory bowel disease. We all know that IBD has become a very important disease, not only in the Western world, but also globally, and also in our region in Asia. There are many countries where IBD has become a very, very important disease. And therefore, this topic of dietary intervention, IBD, I think is a very, very relevant topic. And I hope you can see my slides.
Yeah, we are.
Perfect. So as we know that as the world is evolving over last few hundred years, the dietary pattern also changing. We have increased amount of sugar consumed per capita. We have increased the amount of meat consumption over the last 200 years. We have increased the amount of fat consumption. And all of these result into multiple diseases, including obesity. And look at the evolution of IBD globally in the Western world and also in the other third world, that we find that with dietary changes, the IBD number is increasing, both in the Western countries and in our region. So a diet may have some role to play in the causation of IBD and many other diseases. We all know that IBD happens at three important factors. The most important factor, I think not most important, all are important. The genetics is important, and we know that certain genes are associated with IBD. And second important is environment factors. And in environment, we have mainly two factors, gut microbiome and diet. And gut microbiome and diet are interrelated with each other. With change in diet, the gut microbiome do changes. If diet is aggressive, the microbiome become more aggressive. And therefore, this leads to immune response in the GI tract become aberrant and ultimately leads to IBD. And this is the basic central dogma of IBD pathogenesis. And therefore, diet is an important part in this. So therefore, if you keep diet at the center of IBD, then we can discuss this into three formats. The first format is that does diet increase the risk of IBD? And we'll examine that. Certainly, if a diet is the cause of IBD, then changing diet may be therapy for IBD. And also, if diet is not well, it leads to malnutrition and its consequences. Since diet is we're talking diet, therefore patient perspective comes first. What do the patient believe about diet in IBD? This is a fundamental question every patient asks, that what do I eat? And most physicians say that there's no dietary recommendation. And we don't provide what should they eat. We simply say that take a regular diet, and if anything hurts, then don't do it. Don't use that particular diet. But we don't provide a good dietary suggestion to these patients. And why we not able to do so? Because there are no clinical trials to guide us that which diet is safe and which diet is not safe. But there are certain general principles. I'll come back to that in a minute time. Again, looking at patient perspective, most patients with IBD believe that IBD is caused by diet, and therefore most patients change their dietary behavior. They restrict multiple foods and they eat less. And therefore, the patient are confused with two kinds of thoughts, both negative thoughts and positive thought. Negative thought that IBD is caused by food, and food increases severity of IBD. IBD can worsen food can worsen symptom of IBD, and food can trigger IBD, and there are observations. But on the positive side, patient believes that if I change my diet, will I get better? Again, just to confirm what is the patient perception, there is a study done by Dr. Ahuja from our center and asked patient with IBD. Many questions, but two relevant questions for this talk. That do you believe that diet could initiate IBD? And almost half of patients said yes. Furthermore, if we ask, do you consider dietary habit to have more important role in treatment of IBD compared to drugs? And almost half said yes. So in patient perception, that diet is an important factor in causation of IBD. And therefore, they exclude a lot of diet. A lot of patients don't take dairy products. They avoid whole pulses, they avoid raw fruits, and avoid raw vegetables. So these are the dietary misconceptions in our population. Furthermore, that most patients with IBD, what they do, they decrease the amount of food what they eat. They start eating less. Eating less is dangerous, because eating less will lead to loss of blood, loss of body weight, and you lose weight. And that's why almost 2/3 of patients eat less, having those who have IBD. And also during acute episodes, the number of time they eat also comes down. So these are the important factors we must consider while seeing patients with IBD. So putting everything into a summary of a patient perspective, that most patients believe the diet is an important factor for causes of IBD, and therefore all of us should take time that to consult patients that what are the diet advice we give to patients. I will come back what are the diet advice we can provide to them. Therefore, the diet becomes part and parcel of every aspect of IBD. If you look at the life journey of IBD, starting from onset to different aspect, we find there are multiple stages of IBD, and in multiple stages, there are a lot of dietary factors are in practice, including keto diet, paleo diet, low fiber diet, high fiber diet, and many types of diets. These kind of diets are available to patients. And it's important that we recognize these and tell our patients. As I said, the life journey of IBD goes through multiple phases, and in each phase of disease, the diet advice would be important. And therefore, to do that, the Asian group led by Dr. Ajit Sood made a guideline, so dietary practice guidelines for Asia about 4 or 5 years back. And I'll take some of these expert guidelines into today's discussion. So coming to, is diet a risk factor of IBD? And look at what guidelines suggest. The diet is an important role in the pathogens of IBD, both Crohn's disease and ulcerative colitis. And this is now almost well established. Furthermore, what kind of diet? A diet which is low in fruits and vegetables and high in fat, red meat, and processed food is contributing to IBD. So less vegetable, less fruits, more red meat, more fat, and more processed food are the cause of IBD, are the contributing cause of IBD. And therefore, for Crohn's disease, there are data to suggest that taking less vegetables, taking less fruits, and taking more saturated or trans fat, emulsifiers, artificial sweeteners, maltodextrins, like things, they are aggressive and they are protective for Crohn's disease. And for ulcerative colitis, similarly, the red meat, the dairy products, the artificial sweeteners are aggressive. In omega-3 fatty acid, fish, and fruits and vegetables are protective for ulcerative colitis. We all know that we live in a world which is much evolved, and therefore every day we consume ultra-processed food. What is ultra-processed food? Anything which has sweeteners, preservatives, or stabilizers are ultra-processed food. And ultra-processed food are cause for multiple diseases, including IBD. And it's like what we do simply, a simple yogurt which we make at home is so safe. But a fruit yogurt which comes in package with sweets, preservatives, and stabilizers become ultra-processed food. Look at how we're changing our own diet by complicating the diet. Coming to the second part, that what about if diet is altered in patients with IBD, what happens? Simple thing happen that most patients with IBD have malnutrition. And it's so common that in our country, almost 60% of IBD have malnutrition. And this is very important for us to recognize. Furthermore, those patients who have malnutrition more common in Crohn's disease compared to ulcerative colitis. And also it all depends upon how severe is the disease, what is the extent of disease, and what is the duration of disease. One important thing which is commonly practiced by patients with IBD, and many of us do advise that don't take milk. But milk is an important source of calcium. And therefore, the guideline recommends that milk should not be routinely restricted unless somebody is intolerant. So milk should not be restricted to most patients with IBD unless they have a lactose intolerance. Otherwise, milk should be used because it's an important source of calcium. People also ask that what kind of diet do I take which can prevent my relapses? And in fact, there's no such diet which have been shown which can decrease number of relapses in IBD. Now coming to the most important part, as I said, that a diet is one of the contributing causes of IBD. So can diet be a therapy for patients with IBD? And we know there are multiple diets available, multiple types of, at least 50 types of diet are available, but I'll focus on only a few types of diet today, as the FODMAP diet, the gluten-free diet, the anti-inflammatory diet, some diet which has more carbohydrate, and Crohn's disease exclusion diet. So coming to first two diets, like a low FODMAP diet, where low FODMAP diet can improve symptom of IBD, but it has no role in either induction of remission or maintenance remission. But it can reduce symptom of IBD like blotting sensation, discomfort, if you give low FODMAP diet. And there's no role of gluten-free diet in IBD. There's no doubt about it. There's no role of gluten-free diet in patients with IBD. Now coming to one important aspect in IBD, and there's some data has emerged in the last few years, that's called enteral nutrition. What is enteral nutrition? That any diet you give for medical purpose to any patient with an aim that the disease will improve, that's called enteral nutrition. And this could be partial enteral nutrition or could be exclusive enteral nutrition. So what is the value of enteral nutrition in patients with IBD? There are three types of enteral nutrition. Number one is called elemental, that every carbohydrate, fat, and protein are digested completely to monomers. Like rather than give whole protein, you give amino acids. Rather than give carbohydrate, you give sugar, non-complicated sugar, and fat again are partly fractionated. So this is an elemental diet. Then semi-elemental, which is partially digested, and then polymeric diet. So all are enteral form of diet which can be used. They come into different kind of packets. So let me give you an example. So there's a common scenario that there's a patient with IBD, ulcerative colitis, and who comes to us with acute severe colitis. Right? This is a common situation. Patient with ulcerative colitis and has now acute severe colitis. So these patients are started on IV steroids. The question comes that is there a role of diet in this scenario? In acute severe colitis, is there a role of diet in this scenario? First of all, what is common practice? A common practice in many countries that we keep them NPO, nil per mouth. That's not required. Our guidance suggests for patients with acute severe colitis, adequate caloric nutrition can be given to these patients orally, and one should avoid keeping them nil orally. This is the first intervention. The second intervention, we know that in IBD, the most commonly used drug is steroid, IV steroid. And we know that about 60 to 70% do respond to IV steroid. The question comes that can we improve the outcome of steroid improvement by adding enteral nutrition in that phase of acute severe colitis. And again, this is a study done by Dr. Ahuja and his team from our center, where 62 patients with acute severe colitis were randomized to a group. One group received standard of care, only IV steroids, and second group include IV steroids plus enteral nutrition. Enteral nutrition was given for 7 days, which included 400 grams of peptamine. They come as a tin powder. They come as powder in a tin form. So for 7 days, in this situation, we're given enteral nutrition and exclusive enteral nutrition, and other group was given only steroid. And what we found that normally, as I said, 40% of patients do not respond to IV steroids. 60% respond, 40% don't respond, generally in acute severe colitis. And therefore, the non-response, steroid failure was seen almost in 40%. But those patients who have received, in addition to steroid enteral nutrition, the response rate become much better. Only 25% didn't have response to steroid compared to 43%. It means adding exclusive enteral nutrition during acute severe colitis may improve the outcome with steroid, or may improve responsiveness to steroid in this scenario. So this could be one therapy one might consider in acute severe colitis. Now coming to other concept, that's called anti-inflammatory diet. Again, this is very important. The certain diets are aggressive, or aggressive means they are pro-inflammatory, and certain diets are less inflammatory. So diet which is pro-inflammatory are gluten, which present in wheat, dairy products, processed meat, and processed food, and also those food items which have a tough texture. And these are aggressive food, and these are safe food, like giving rice, maize, ragi, pearl millet, fresh yogurt, fresh chicken, fish, and egg, and many vegetables. These are less inflammatory. These are pro-inflammatory. So these diet increase inflammation not only in IBD but many other conditions. So the question was that if you use anti-inflammatory diet in IBD, will it have any effect? I think I'd like to emphasize that doing a clinical trial on dietary practices are very difficult, right? And very difficult to control such diets. Second thing, that we all know that in ulcerative colitis, the fecal microbiome transplantation is efficacious. In at least 30 to 40% of patients with ulcerative colitis do respond to FMT. But FMT you give for a few weeks, 6 weeks, 8 weeks. But response of them lasts for that much time. And as you stop FMT, the disease relapses. What FMT does? FMT does that it improves the microbes in the GI tract, which are more beneficial compared to those who are aggressive. It means it improves dysbiosis. The question is that if in IBD or in ulcerative colitis, we give FMT for a few weeks and then maintain by some form, that we maintain a gut which have less dysbiosis, will it have a long-term implication? And to test this hypothesis, a study was done by Dr. Ahuja and Saurabh Kedia from our institution. And what is the question here was that if in patient ulcerative colitis, which are mild to moderate active, you give FMT at induction phase and maintain on anti-inflammatory diet. So will it be better if you maintain this patient on anti-inflammatory diet, will the remission persist? And this study was a randomized controlled trial, which was published in Gut in 2022, where a group of patients were given FMT, 7 sessions of FMT, weekly sessions, and along with that anti-inflammatory diet, and talk to you what this inflammatory diet is. And other group received the standard medical care. And after those patients who have a response, these patients were maintained on anti-inflammatory diet in this group, and other group maintained on only 5-ASA. And their treatment optimized if they required hiking of dose 5-ASA, that was done. So and then this patient was followed every week till 48 weeks. What we observed that those patients who had FMT and anti-inflammatory diet had a better clinical response compared to standard of medical care, 65% versus 35% at 8 weeks. And also look at all composite, including mucosal healing. 1/3 of patients had a response in those who have FMT and an anti-inflammatory diet compared to standard of care, which was 8%. And this also persisted at 48 weeks. Both responses were better in those who had FMT and maintained on anti-inflammatory diet. Simply means that after giving FMT, if you maintain this patient on anti-inflammatory diet, 50% patient will be better. Therefore, we concluded that combining FMT with anti-inflammatory diet is beneficial in patients with ulcerative colitis of mild to moderate severity. Coming to a last diet which I will discuss today will be Crohn's disease Southern diet. Again, we know that certain diets are advised for Crohn's disease. So what is a Crohn's disease Southern diet? We know that a normal Western diet having high fat, high carbohydrate, this diet leads to more aggressive bacteria in the gut and leads to dysbiosis. And we can improve this dysbiosis by giving more fruits and vegetables and avoiding wheat, red meat, emulsifier, and maltodextrins, as we discussed just now. And therefore, this study published in Gastroenterology again confirms that those patients with Crohn's disease, if you give them either internal nutrition or internal nutrition with Crohn's disease diet, both are beneficial. Simply means that those patients with Crohn's disease, one should avoid animal fat, wheat, dairy, red meat, emulsifier, and encourage them to eat more fruits and vegetables. Again, two studies from India, and both suggest that in certain number of patients with Crohn's disease, the exclusive internal nutrition may be beneficial. So putting that into context and a summary, that exclusive internal nutrition can be effective in adult patients with Crohn's disease, but efficacy is less than corticosteroids. But main issue is to maintain this patient EN, because EN is expensive. And once you give this patient EN, one must be aware that this patient can develop multiple micronutrient deficiency, and therefore we should take care of those. One question is always asked by patients and also by colleagues, that what are dietary fibers in patients with IBD? The data on ulcerative colitis is limited, but data on Crohn's disease suggests that high fiber diet is beneficial in patients with Crohn's disease, because fibers improve bowel function and symptoms of Crohn's disease, and also avoiding a high fiber diet increases chance of flare. And therefore, both ECO and Asian guidelines suggest that all patients with Crohn's disease should be given a high fiber diet, except for those who have strictures in the gut, and therefore high fiber diet should be used in patients with Crohn's disease. One last part, that one other question one patient can have. Again, this is a young lady who gave a birth to a baby girl, and he asked that what should I do so that my baby does not develop IBD. And looking at evidence, what it suggests that if you breastfed this infant for 12 months compared to 6 months, decreases the risk of both ulcerative colitis and Crohn's disease by high number. Odds is just 0.2, means you protect them by 80%. So asking these mothers to breastfeed their infants for a longer period of time may have benefit. And for the mother, they should avoid again those foods which are pro-inflammatory in nature. So to end my talk, I want to introduce to you again this one creation of Vinita Huja and his team, which is a diet app which is called IBD NutriCare. This diet app is available both on App Store and Google Play. This is freely downloadable, and this diet have all the features that patient can maintain their diet on this thing. They can maintain disease activity, and you can see online. So maybe advise all your patients to look at or download IBD NutriCare. Their whole instructions are given as how to use this diet app. So summarizing everything, there is a gap between patient and physician. We as IBD physician and also as a gastroenterologist or internist, we must ask patient about diet, tell them what to eat, what not to eat, and we just discussed which food are more aggressive, which food are less aggressive for IBD, and also look after malnutrition in them. Which diet is harmful? High fat diet, high sugar diet, high salt diet, emulsifiers and sweeteners are aggressive. they should be avoided. A diet which is useful is a high fiber diet, fruits and vegetables, fermented foods, and food which have a omega-3 fatty acids like fish. The diet can have a role in controlling disease activity, and we just discussed that anti-inflammatory diet with FMT has a power of healing of IBD. There's a role of exclusive enteral nutrition in adult patients with Crohn's disease, and also exclusive enteral nutrition improves the efficacy of steroid in those patients who have acute severe ulcerative colitis. One can also use Crohn's disease exclusion diet along with the partial enteral nutrition in patients with Crohn's disease. I would advise that you please recommend IBD nutricare to all your patients with IBD, and diet with more and more advancement, diet may become an important part of therapy. Before we close, I'd like to acknowledge Vinita Huja, who is a very dear friend, and he guided me prepare this talk. I'd also like to acknowledge all the dietitians of IBD and celiac clinic at AIIMS, and all our colleagues and collaborators who help us doing our work both in IBD and celiac disease. Thank you for your attention.
Thank you, Professor Makharia, for your very insightful talk. We'll take 1 or 2 questions from floor because he's online and maybe not available later. Please.
Meanwhile, I can take her portal in the audience. Yeah.
Govind Anil Arora here. I wish you were with us physically.
Good afternoon,
Hope
sir.
you are all safe.
No, all good, sir. All good, sir. Minor ankle injury, sir.
Yeah, I think your first slide was very good. It showed the epidemiological trend of changing diet patterns over the last century or so. So that has led not only to increase in prevalence of IBD and also diabetes, dyslipidemias, metabolic associated liver disease. Do you think the same diet is causing everything? So that way, patient with IBD and both ulcerative colitis and Crohn's, are they more likely to have diabetes, hypertension, dyslipidemia and mast cell, or there is a different type of diet for different diseases? Because the sugar, fat and the processed food is the same denominator in the different diseases.
So I think very good question. I'm reviewing a paper from US, and we saw that patients with IBD have a higher risk of diabetes, hypertension, and other metabolic diseases. Yes.
And secondly, when you talk of alteration in the diet, say for 2 weeks in trials or 3 weeks or 6 weeks, but how does it translate? Can you switch on to the day-to-day life in a person who is working, in a young man who is in the work? How does it translate into clinical relevance?
So in the clinical practice or in clinical research, the clinical trials are done only for a certain period of time. But IBD is a lifelong disease. Diabetes is a lifelong disease. Therefore, it's about changing behavior of individual. What we talk of a short-term intervention or the clinical trial. But dietary practices are all about changing behavior of the patient. That if you go to what to avoid, not to avoid only for 6 months, you might have to avoid for your life. Right. And again, the important thing like in celiac disease, you avoid for completely, you stop wheat. But it's not scenario in IBD. Like you decrease amount of red meat. You still have red meat, but much less than what you're having. So it's about decreasing the amount of consumption.
And finally, the changes which tend to improve the clinical parameters and the response rate. Is there a corresponding improvement in the microbiome pattern also of fastidious organism versus pathogenic organism?
Yes, a lot of work being done now. That the diet, after change, again, the Kohujal study also shows that after giving anti-inflammatory diet, the gut microbiota changed to less aggressive. There are more beneficial bacteria compared to less aggressive bacteria. So, and there are multiple studies available that with dietary intervention, there is an improvement in gut microbiota.
And when you talk of this gut microbiota in IBD and in Crohn's and ulcerative colitis, do we talk of different microbiota in the small and large bowel in ulcerative colitis and Crohn's? Because Crohn's by default is a small bowel disease and ulcerative colitis in large bowel.
The most studies are there from large intestine, both ulcerative colitis and Crohn's disease. Most people are what we're doing, they're doing it whole gut microbiota by looking at stool sample, which is the ultimate product of all the bacteria, or not all bacteria, but bacteria, fungi, viruses, or archaea. All of them are looking at the whole gut microbiome. But they are different in colon and they're different in small intestine. There are studies in Crohn's disease, biopsy samples. Even in Crohn's disease, there is a more dysbiosis in small intestine, certainly in the whole stool and whole colon, but also in the small intestine.
And I'm really grateful for opening the floodgates for milk and the roughage for IBD, because that is a reflex response to a patient who has diarrhea. Stop milk and stop roughage. I am happy you have clarified the issue. Thank you, and I think you deserve a loud round of applause.
Thank you very much. Now we have a very eminent speaker, Dr. Anil Arora from Delhi. If we saw today the standard of presentations and the work we have done here, I think most of the thanks will go to Dr. Anil Arora. He's our friend. Give him a good hand. Friend, and he never says no to anybody who asks for help, patients or doctors, and he's always been keen on improving our endoscopic and GI programs in Nepal. So every time we go to Delhi, we get an update of quite a long time. Thank you very much, Dr. Anil. And his topic is endoscopic management of gastroesophageal reflux, when and how. Whenever you are ready, sir.
Thank you, sir. At the outside, I am extremely grateful to Nepalese Society of Gastroenterology, especially Dr. Mukesh and his team for giving me this opportunity. For me, coming back repeatedly to Nepal is like coming back home after a day's work. Nepal has been very dear to me because I have been involved in the setting up of the gastroenterology department in various hospitals in Nepal. I am so glad to see such an excellent work being done by the youngsters, and which is always raising the bar to newer and different levels. The topic which was allotted to me is endoscopic treatment of gastroesophageal reflux disease. Can we have these lights off if possible? All these main lights. Endoscopic treatment of gastroesophageal reflux disease. When is it needed? How is it done? And who is it meant for? In fact, what is reflux? Reflux by default means you have a pressure gradient between the abdominal stomach and the thoracic esophagus, which would favor the retrograde movement of the gastric content into the esophagus, but is not prevented by anti-reflux barrier. That is the reflux. So there are two components to this anti-reflux barrier. See, this is the esophagus, this is the stomach. The stomach is supposed to be producing a lot of acid, which has to be by default going into the intestine for digestion of food. It has no business to be traveling up. So you have two mechanisms. You have this complex called lower esophageal sphincter, or so-called the internal sphincter of the G junction. Then you have the crura of the diaphragm, which tends to give a gripping onto the inner sphincter, which is also referred to as a external sphincter. So you have two sphincters which are trying to guard the upcoming acid from the stomach up into the esophagus. So what is reflux? Reflux by definition is an subjective feeling. That means it causes heartburn because you have an acid which is tending to pop up into the stomach. So any person who has retrosternal burning, there can be no differential diagnosis. This is the only pathognomonic symptom of reflux, that you have a retrosternal burning. But then reflux can also be quantified, it can also be objectivized. That is, once you are able to see the damage being done in the lower end of the esophagus because of the splashing of the acid which pops up from the esophagus and tends to damage the lower end of the esophagus. So all of you are aware of this Los Angeles classification of the degree of the reflux esophagitis. Depending upon the size of the erosion, the location of the erosion, and the extent of the erosion, you can classify the degree of esophageal reflux as grade A, B, C, and D, which can subsequently be confirmed by doing this objective way of measuring the acidity in the stomach called 24 hours ambulatory pH monitoring. I don't know whether it's being done routinely in centers over here or not. So grade A reflux is anybody who has erosion of less than 0.5 centimeter. Erosion on a single fold of more than 0.5 centimeter is grade B. If you have erosion which is extending between the two ascending gastric folds, that is the grade C, and when you have a confluent 75% circumferential ulceration, that becomes grade D esophagitis. In fact, most of us, when we are doing endoscopy, we should retroflex the scope and try to see the gap between the esophagus, this is the esophageal hiatus, and the scope. And we should try to see the distance between the esophageal hiatus and the scope. And depending on that particular gap, we tend to classify this thing as different types of grading of the loosening of gastroesophageal junction, which is graded as hill 1, when there is hardly any space between the esophagus and the gastric lumen. Grade 2, when you can pass one scope in addition to the scope which is already present there. You have grade 3, when you can pass two scopes along with the scope which is already present through the hiatus. And grade 4, when you have a huge hiatus hernia, when you can even see the esophageal mucosa, like in this picture from the retrospective, flexed view. So there are 4 grades of Hill's grade when you try to define the loosening of the gastroesophageal junction. I think on our routine endoscopy examination, it gives us a lot of credence if we start routinely reporting how loose the gastroesophageal junction is. What causes reflux esophagitis? There are different important events which will cause symptoms of reflux esophagitis. So this will lead to reflux events, and it's basically primarily because of the repeated transient relaxation of the lower end of the esophagus. As I showed you, you have the stomach, you have the esophagus, and you have the lower esophageal sphincter. Intermittently, it transiently relaxes, leading to the upcoming acid into the esophagus. That is the single most important cause of gastroesophageal reflux disease. At the same time, esophageal peristalsis may be poor, so that any acid which comes up is not being pushed back into the esophagus, into the stomach, and that is, there is a poor emptying of the esophagus, and at times you may have a slow gastric emptying, so that stomach gets full repeatedly, and hence since it cannot go down, so the only passage which is left open to it tends to come up. So one of the most important reasons which is very poorly understood and which has been very poorly investigated is something called transient lower esophageal sphincter relaxation. Repeatedly, nobody knows why. This is the G junction. It is innervated by the vagal afferent, which has both have afferents and efferents which go into the medulla oblongata. We do not know whether the problem lies in the afferent loop, whether it lies in the medulla oblongata, or it is the efferent loop. Something happens that repeatedly the lower esophageal sphincter tends to relax. This is the most important cause of development of gastroesophageal reflux disease, which is so common in, say, we have a data from Indian population, 20% of the patients in India suffer from gastroesophageal reflux disease. And almost all those who do not have hernia, if the reflux is occurring, it is occurring because of transient esophageal reflux disease. So please remember that if there is no hernia and still the patient has a reflux, it is because of the transient lower esophageal reflux esophagitis. Then you have something called hiatus hernia. What is this hiatus hernia? Hiatus hernia is the part of the esophagus which crisscrosses the diaphragmatic region and tends to get up into the thorax. That is a hiatus hernia. What does it lead to? It will again lead to relaxation of the lower esophageal sphincter. There will be weakness of the LES and there will be weakness in the crural diaphragm and a lot of acid will be coming up. I have already informed you how we grade the hiatus hernia endoscopically, grade 1, grade 2, grade 3 and grade 4. This is so important when you tend to devise the therapy of treating reflux esophagitis. So how do we treat reflux? We treat it medically, and all of us know as seasoned gastroenterologists that we have to change our diet style and lifestyles. We have to give proton pump inhibitors, and when they are not enough, you can add a night dose of H2 receptor antagonist. At times, you may have to give prokinetic drugs, so there is a forward movement of the gastric contents. You may even use sucralfate. If you see the results of the medical therapy for treatment of reflux esophagitis, it clearly shows that about 40% of the patient, in spite of using very potent PPIs, still do not have adequate control of the reflux. So this is a subgroup of the patient which is still troublesome with medical therapy. So the problem, another problem with medical therapy is how long will you keep on giving? Here is a young man who is an executive in a firm, he works in IT, recently married. How long will you give him reflux esophagitis? So we do not know how long. Side effects of the therapy have to be kept in mind. 20-year-old guy, he cannot keep on taking the medicine for another 50 years. And then 30% of the patient may have refractory reflux which will not respond to PPI. In addition, PPI will only try to neutralize the acidity in the stomach. If you have a hernia which pushes a lot of volume into the esophagus, that cannot be prevented by the PPIs because PPIs will only try to stop the acid production. So there are, ladies and gentlemen, therapeutic gaps in management of reflux esophagitis. So we have 60% of the patient who do not respond to medical therapy, or who respond to medical therapy. That means 30% of the patient do not respond. I'm sure in your own practice, most of the gastroenterology would agree that not more than 5% patients are convinced for surgery. So what happens is in 20 to 30% of the patient who are not responding to medical therapy, who do not want surgery. That is where we have to fill in endoscopic therapy. This is the subgroup of the patient who are reluctant to take PPIs or they are insensitive to PPIs, that means they are not responding to PPI, and when they do not want a surgical intervention, especially when they do not have a hiatus hernia. In fact, if you see the history in the past, there was a slogan by Dr. Hogan that similar to the holiday turkey, esophagus was stuffed, stitched, baked by enthusiastic endoscopist intent. People used to, Dr. Chaudhary will remember, Dr. Dinesh and Dr. Romela, that people used to inject bulking agent, submucosal implants. They would inject collagen in the gastroesophageal junction so that this junction becomes swollen and fibrosed and prevents the upcoming of the fatty acids. But then it has been shown that over a period of time, only few therapies on endoscopic arena have survived the onslaught of upcoming surgical fields, and these have included US FDA therapy like radiofrequency ablation or strata. We have newer therapies which I will be talking of it. So coming on to the first therapy which was available was to basic aim of gastroesophageal reflux therapies. Somehow you try to tighten the gastroesophageal wall, somehow you try to strengthen the valve so that the reflux does not occur. So why do we need endotherapy in patients with reflux? It is less invasive, it is cost effective, it gives you good control of the symptoms, it is relatively safe and improves the quality of the life, especially in a young patient who is not responding to therapy. So who are the candidates who require endotherapy? These are the patients who are PPI responder but somehow they don't want to continue it for a long period of time. Those who have mild esophagitis, those who have Hill's grade 1 and grade 2 hiatus hernia, not large hiatus hernia, and those who have documented reflux, that means acid exposure time is more than 4%. But then we should also remember that we should not do endotherapy if there is a primary esophageal disorder of the esophagus, if there is a primary esophageal motility disorders, or if the patient had Barrett's esophagus or esophageal stricture, or in a pregnant woman. So be clear that there are contraindications to endotherapy. So what does endotherapy does is it is giving us a way forward in treating this patient. So first modality which came into being was this procedure called strata or radiofrequency ablation. So what is done is we put in a flexible catheter, which is a 4-channel catheter. It gives you radiofrequency transmission through the titanium electrodes, and these electrodes will go and deliver the energy in the submucosa at a depth of 1 to 2 centimeter, from starting 2 to 3 centimeter below gastroesophageal junction and going up to the lower end of the esophagus. So you are giving radiofrequency ablation, you're causing inflammation and fibrosis in the submucosa, leading to tightening of the wall by causing fibrosis. So what are the results? By this technique, you are able to remodel the GE junction, which was loose and patulous. You have made it tight and more fibrotic. What does it do? It prevents TLSER and hence improves the response rate. So 70% of the patient do have response, and it has been shown that a substantial number of the patients are able to stop the PPI once you are able to do this strata therapy. And this is the only therapy in which we have a 10-year long-term follow-up which is available and shown this efficacy. Then this concept came, learning from the surgeons, that why don't we go inside the stomach, pull the gastroesophageal junction in this technique called TIF or transoral incisionless fundoplication, and try to create a wrap around the lower esophageal G junction, so that this wrap causes tightening of the valve, so that valve becomes something like what surgeons have been doing. We had Dr. Janendra Chaudhary who showed us during poem how they do this fundoplication. She's using this technique. We are able to create a fundal wrap endoscopically to the tune of about arc of about 270 degree. It has been shown that using this technique over 10 years, there is a substantial reduction in the reflux, and most of these patients do well. So these are the patients who can be taken up for TIF therapy after, if there is a reflux after poem. I don't know whether Dr. Janendra Chaudhary during his debate, he said that if the endoscopist gives him a technique of doing fundoplication, he will hand over all the patients to an endoscopist for poem. I think this is the answer. If there is a reflux after poem, you can use this technique called TIF or transoral incisionless endoscopy. Then came this technique of using a ultrasound surgical endostapler called Moose technique, which gives you good results in control of the reflux. And finally, I'm sure most of you have heard of this fellow called Hinoi, the person who discovered this technique of doing poem for third space endoscopy. He came with this newer idea and novel idea of using anti-reflux mucosectomy. So what it did is he went into the stomach, and after leaving 1 centimeter below G junction in a 270 degree arc, he did a organ plasma coagulation of this G junction. And as he was causing injury to the submucosa, that leads to healing of this submucosa. And he has shown that after almost 10 years, you have achieved a complete reflux. So a very simple procedure of creating a submucosal inflammation below the G junction with this technique called anti-reflux mucosal ablation may be an excellent technique which we are routinely using in Gangaram Hospital. We have done more than 100 cases. So this is a subgroup of the patient, a young man, no large hiatus hernia, responding to PPI, you are worried about the side effects, just do an ARMA. It can be done on OPD basis and patient can be discharged the next day. So the first case which was done by Professor Hinoi in 2010, he followed up the same lady after 12 years, and you see this type of patulous J-junction had become totally fibrosed with excellent result without any problem. So anti-reflux mucosectomy is a relatively new technique, and it gives you excellent results. And recently it has been shown that even after the hype of having reflux after POEM, you can do this ARMA procedure routinely, because in our practice, we have done more than 600 POEMs in Gangaram Hospital, and the degree of the reflux is minimal. In fact, not more than 5% of the patient has substantial reflux. So reflux should not be routinely done during POEM, because 5% of the patient who have symptomatic reflux can be easily managed with medical therapy. If they do not respond to medical therapy, you can do this as an OPD procedure called ARMA. So this is the one good technique of doing gastric myotomy in a patient who already has POEM which has been done for anti-reflux procedure. So we have Dr. Amol Bapai from Pune, who had invented this technique of using fundoplication during the same procedure called POEM F or F POEM during procedure of POEM for Achalasia cardia. But most of us realize that POEM F is a complicated procedure. Majority of the patients undergoing POEM do not have substantial reflux. And if somebody develops a reflux, you can always come back and do POEM. And hence, there is no need of routinely doing POEM F. So this is the technique of doing POEM F, which is slightly complicated. What you do is, when you go inside when you do your POEM, you make a nick in the anterior wall of the muscle, go into the peritoneal cavity. See, we are already into the peritoneal cavity. From there, you go and look for the stomach, put in a stitch onto the stomach after identifying that you are in the spleen, and then you get back onto the stomach, put in a suture, and then try to suture this. See, this is the peritoneal cavity. You can see this is the stomach, that is the liver, and then you put in two suture, one onto the anterior wall of the stomach, another to the lower end of the esophagus, and try to achieve this procedure called POEM F. This is something which is technically feasible, and as I said, it is not needed in majority of the patient. So this is what we do get after doing an F POEM. You can achieve a good fundoplication in patients who have reflux disease. So to sum up, ladies and gentlemen, current data for endotherapy of reflux supports clinical efficacy and safety. Endotherapy for reflux is minimally invasive, is usually outpatient, and has been gaining popularity in recent years. Now we have made a policy in Gangaram Hospital that all young patients who have significant reflux, once you control their reflux with PPI, we offer them ARMA therapy, because this is a simple, practically safe therapy which over long-term period of time can avoid the need of long-term ingestion of PPIs. Partnership between endoscopists and surgeons to treat an anatomic defect, certainly it eliminates the need for suboptimal long-term PPI therapy, which has its own potential side effects. In fact, it fills a void in current anti-reflux therapy, because most of the patients who come to us for treatment of the reflux, if you convince them that they should have surgery, majority of them do not agree. So this can act as a bridge between a medical therapy and a surgical therapy. Endoscopic and anti-reflux procedure are a component of the broader comprehensive multimodality management of patient with significant disease. So patient who comes to you with reflux esophagitis, majority of these can be controlled with lifestyle changes, that means small frequent meals, avoid snacks, avoid red chilies, spices, oil and alcohol, lose weight. 70% of these patients will respond to PPI. Those with PPI who do not respond can respond to endotherapy with either TIF, strata, or the currently available therapy of anti-reflux mucosal ablation. Finally, 10% of the patient, especially those with large hiatus hernia, those who do not respond to medical therapy, or those with severe esophagitis or Barrett's esophagitis, should be given therapy with the surgical intervention. So this is the summary of what I have told you today. So we have a connecting bridge in patient with reflux esophagitis. 30% of the patients who do not respond to therapy and who do not agree for surgical intervention, especially when they do not have a hiatus hernia, are the best candidate for endotherapy in reflux esophagitis. Thank you.
Thank you very much, sir, for the great information and the wonderful presentation. The question and answers will be taken at the end of the session. So, in continuation with the international speaker session 2, our next speaker is Dr. Mohammad Saiful Islam. He'll be talking about the genetics, lifestyle, and gut microbiome in mast cell. How do they interact? Dr. Mohammad Saiful Islam, he is working at Bangladesh from Dhaka, and he is practicing as a gastroenterologist in Sheikh Russell Hospital. So the stage is yours, sir. Thank you, sir.
Good afternoon, everyone. Thanks the organizing committee for inviting me from Bangladesh and give me the opportunity to present my speech here in this great platform. So my title of this presentation is Genetics, Lifestyle, and Gut Microbiome in MASLD, and how do they interact. So you know that a name of the disease can describe the disease, and it has a great impact on the patient, on the healthcare profession, and over the society. So any misname can make confusion and mistrust between the patient and doctor. So many suggest that the name that initiate with the term the non may decrease the significance of the disease. So you all know that the previous name is non-alcoholic fatty liver disease. And currently we are in the era that the name is changed to MASLD, that is metabolic dysfunction associated steatotic liver disease. So if we go through this slide, we see the journey of the nomenclature of the fatty liver disease. That is 1845, that's the Thomas Edison first described the fatty liver, and 1880, the term NAFLD or NASH was first coined by the Jürgen Ludwig. Then after 20 years, in 2002, report from the ASLD STC, they first declared to raise their voice to change the nomenclature to metabolic steatohepatitis, but this time no consensus was happened. And after that, there were several attempts in 2005, 2009, 2011, and finally in 2020, a consensus of global leaders that in Delphi method, they suggested that the name must be changed to metabolic associated fatty liver disease in 2020. And finally, in 2023, a multi-society Delphi consensus statement on new fatty liver disease nomenclature, they suggested that the name should be changed to metabolic dysfunction associated steatotic liver disease. So we give, through the define, how do we define the fatty liver disease is the previous, that was called the NAFLD, that is non-alcoholic fatty liver disease, the presence of only hepatic steatosis more than 5% in the absence of other etiologies such as alcohol, viral hepatitis, or any other steatogenic drug. But this is the diagnostic criteria of the MFLD, metabolic associated fatty liver disease, that any person, any adult have presence of hepatic steatosis detected either by the imaging or blood biomarker or any histology. If the patient is overweight, then he must have the MFLD, or any type 2 diabetes mellitus, he must have MFLD, or in case of any lean or normal weight patient, if he have any 2 or more of the metabolic risk abnormalities, that is waist circumference more than 102 by 88 centimeter, and blood pressure more than 130 by 85, and the plasma triglyceride level, plasma HDL level, pre-diabetes, or the HOMA-IR, that is greater than 2.5. If any lean or normal weight patient, if any 2 of the criteria, must have the MFLD. And finally, this is the MASLD, that is metabolic dysfunction associated steatotic liver disease. So again, any patient or any adult having the hepatic steatosis is proved either by imaging or blood biomarker or by histology, the next question must be raised, that is, does the patient have any cardiometabolic criteria? So what are the cardiometabolic criteria? In the right side of this slide, I am showing the criteria again, that is criteria based on BMI, fasting blood glucose level, or towards or post-load glucose level, or type 2 diabetes or treatment on type 2 diabetes, blood pressure, plasma triglyceride level, and plasma HDL cholesterol. So any one of the 5 cardiometabolic criteria present in any person who have hepatic steatosis must be considered for the diagnosis of MSLD. And so next question again is there is any criteria of hepatic steatosis, then if the answer is no, then he must be considered for the final diagnosis of metabolic dysfunction associated steatotic liver disease. And if there is presence of alcohol, then it should be considered as metabolic associated alcoholic liver disease. So I have to talk several factors that are contributing to the development of the MSLD. Then one of the most important factors that is genetics. Several genes were involved in the development of MSLD, but there is single nucleotide polymorphism in genes that contributing to hepatic uptake of fatty acid, lipid droplet biology, very low density lipoprotein transportation, de novo lipogenesis, gluconeogenesis, insulin resistance, endoplasmic reticulum stress, and oxidative stress. These are the most common genes that are studied for the progression of fatty liver disease. The most commonly studied, and I have also done some study regarding this genetic polymorphism, that is PNPLA3, TMSSF2, GCKR, MBO87, and others. So this is the most common gene, that is the PNPLA3, that is mostly expressed in the liver, adipose tissue, and the retina, and this function like lipid droplet remodeling and lipid metabolism. And when the polymorphism occurs, they lose their function, and the ultimate effect is increased fatty liver, NASH, fibrosis, and ACC. And another gene, that is TM6XF2, that is expressed mostly in the liver and small intestine, and their function is VLD and cholesterol trafficking and secretion. And when their mutation occurs, again the effect is increased fatty liver, NASH, and fibrosis. These are another 2 genes important, that is GCKR, which mainly expressed in the liver, and their function is regulation de novo lipogenesis, blood glucose homeostasis. And the ultimate effect is the fatty liver and NASH and fibrosis. And lastly, again another important is the MBO87, inubiquitous and liver enriched. And when the mutation occurs, ultimate effect is fatty liver, increased fatty liver, NASH, and fibrosis. This is my 2 publications which I have done, and that is what published in 2021, and another is 2023. In these 2 articles, I try to find the familial clustering of fatty liver disease among the family member of NASH cirrhosis patient, and the second one, I try to find out the role of genetic polymorphism in the development of MFLD among the family member. This cross-sectional observational issue, we include 50 NASH cirrhosis patient and 81 family member. Family member were screened for fatty liver by ultrasonogram, and insulin resistance, metabolic syndrome, PNPLA3 polymorphism, and staging of liver stiffness by FibroScan were done. And interestingly, among the 81 family member, almost 58% were found having fatty liver. And PNPLA3 polymorphism were higher, that is 80% in fatty liver group, then 55% without fatty liver group. A subject with PNPLA3 polymorphism had 3.33 times increase in odds having fatty liver. So PNPLA3, this variant is major genetic determinant in the development of NFLD and NASH. And there is a single nucleotide polymorphism in the position of 148, that is the conversion of C to G. And remarkably, the association between the PNPLA3 polymorphism and liver fat was independent of major differences in the body composition, diabetes, and serum lipoprotein level. This is the picture of the PNPLA3 gene and the number of 148 position where the polymorphism occurs from C to G. This is the NASH cirrhosis group where the total 48 data were available, and among them almost 80% have the genetic polymorphism in PNPLA3 either in the form of CC or CG or GG. And this is the PNP polymorphism among the family member. Here also the 70% have the PNPLA3 polymorphism either in the form of CG or GG. So among the 81 family member, we have almost 47% those have fatty liver. Among them, almost 80% have genetic polymorphism either in the form of CG or GG. So next one important factor is the lifestyle. This is a rural picture of our Bangladesh. I don't know whether this kind of machinery is available in Nepal or not. Do you know that what they are doing? This is called a dheki in Bangladesh, and in the previous year, a lot of years ago, the rural women were involved in different lots of work. They are husking paddy. But the time being, this type of instrument now is rare and obsolete because nowadays newer machineries have involved, newer machineries have come to replace this dheki. And in 2018, we have done a nationwide survey in Bangladesh to see the prevalence of fatty liver disease. And very surprisingly, it was 33.3%, and village women were mostly involved. Because the lifestyle is changing, they are not involved in this type of work anymore. So in recent year, NFLD has become the biological marker of social affluence and sedentary lifestyle. This is our recent publication where we see the longer sitting time and bulk amount of rice intake are associated with the increased risk of metabolic dysfunction associated fatty liver disease. This case control study conducted among the source population, 2,000 diagnosed with MFLD criteria and 100 healthy control. And quantitative approach such as interview were applied to measure dietary practice and physical activity level. Most, that is 89% of MFLD patients were web-based, used to sedentary lifestyle and took outside foods than their counterparts. Moreover, nutrient intake analysis per day demonstrated that MFLD patient consumed significantly higher amount of total energy, that is 2,288 versus 1,570 kilocalories per day, and calories from rice, protein, and fat than their counterpart, that is control. 86% of the MFLD patient consumed a surplus of 268 kilocalories per day, indicating energy was not burned through physical activities, while 89% of control have negative energy balance, that is minus 360 kilocalories per day. So multivariate analysis revealed that more than 300 minutes sitting time. So with a doctor are mostly sitting at longer time in the throughout the day. More than 300 minutes sitting time, more than 300 gram per day carbohydrate consumption, more than 950 kilocalories per day from rice, more than 50 grams per day from fat, less than 2,000 kilocalories per day energy expenditure, BMI more than 25 kg, eating outside, risk factor for development of MFLD. So these are all the part of our lifestyle. So longer sitting time, outside eating habit, more energy from carbohydrate, especially rice, and a daily positive energy balance lead to obesity and consequently the increased risk of MFLD. Another important factor is the gut microbiome. The human gut microbiome is made up of 10 to 100 trillion microorganisms, mainly bacteria, with this number about 10 times higher than the number of eukaryotic human cells, and susceptible to environmental and pathophysiological alteration. The composition and function of the microbiota are determined by a variety of host and environmental factors, including diet, geographic location, physical activity, and medication. So there are several studies to determine the types of microbiota in presence of human gut. So compiled data from these studies that identified 2,172 species isolated from human being and classified into 12 different phyla, of which 93.5% belong to proteobacteria. These are the most common, most important and most common phyla found in the human gut microbiota, that is proteobacteria, firmicutes, bacteroidetes, and acinitrobacteria. And among these four phyla, firmicutes and bacteroidetes are most important. And they play a role in the development of MFLD. Firmicutes play a significant role in the relation between the gut bacteria and the human health. And many of the members of the phylum break down carbohydrates in the gut that can be digested by the body enzyme such as dietary fiber and resistant starch, and this process is called fermentation. While firmicutes play a beneficial role in their gut health, an overgrowth of certain species within this phylum can contribute to gut dysbiosis, which is associated with NFLD progression. And dysbiosis involving firmicutes can lead to enhanced energy extraction from food, contributing to weight gain and obesity, which are the risk factor for the NFLD. An increased gut permeability, often referred to as the leaky gut, which allows microbial products such as lipopolysaccharide to enter the bloodstream. And this triggers the systemic inflammation and can directly affect the liver, exacerbating the NFLD progression. So another important phylum is that the bacteria, although some bacteria species can be opportunistic pathogens, and many bacteria are symbiotic species highly adjusted to gastrointestinal tract. And bacteroids digest carbohydrates by a series of metabolic pathway. Bacteria produce anti-inflammatory metabolites that can help maintain gut integrity and modulate immune response. So bacteroids, in case of gut dysbiosis, the protective effects of the bacteroids are diminished, and this can lead to the increased gut permeability and often reverse the leaky gut, which allows microbial toxin like lipopolysaccharide to enter the portal circulation. And lipopolysaccharide can active inflammatory pathway in the liver, contributing to the liver inflammation and fibrosis and exacerbating the NFLD. So in a healthy gut, Firmicutes and bacteroids are the dominant bacterial phyla, contributing to key functions such as digestion, energy regulation, and immune modulation. The overgrowth of Firmicutes species increase the capacity of the gut microbiota to harvest calories from indigestible carbohydrates, thereby promoting obesity and key risk factor for the NFLD. So this is the gut-liver axis, you all know that. In the right side there is the gut lumen. When the anti-inflammatory product can, in case of gut microbiota dysbiosis, the anti-inflammatory product can directly go to the portal vein, and through the portal vein they go to the liver, and there they activate the hepatic stellate cell, the Kupffer cell, and increase the lipogenesis, and the ultimate result is the formation of simple steatosis, then to cirrhosis and HCC. So this is the combined picture where the multiple factors that I am showing that are development that trigger the formation of NFLD. We discussed about the diet and lifestyle that are the in part of the environmental factor. There is metabolic factor, that is gut microbiota, and there is some genetic polymorphism. These in several pathways, in several mechanisms, all may trigger the inflammatory process in the liver and ultimately the development of MSLD. So this is the last slide from my presentation, and we show that there are multiple heat for the MSLD. The heat mainly involved in the environmental factor, dietary factor, physical activity, and gut microfilaria, gut microbiota, and genetic factor, oxidative stress, immune-related, and metabolic factor. These are cross-linked with triggers some more other risk factors that are the obesity, insulin resistance, hyperlipidemia, and inflammation. The ultimately and the final result is the development of MSLD. Thank you very much for your patience hearing.
Thank you, Dr. Mohammad Saiful Islam, for your wonderful insights on MSLD. So because due to time constraints, so we'll be taking just few questions from the audience. Now the floor is open for question and answers. Doctor, please, Dr. Mohammad Saiful Islam, can you be in this stage? And Dr. Anil Arora sir as well.
Yeah, nice presentation. My question is a very basic question. You say 5% of fat is fatty liver. 5% of what? Hepatic cells?
It can be determined whenever it exceeds the 20% of total liver volume, that will be detected by the ultrasonogram.
No, the definition of fatty liver is when we have more than 5% of fat.
Yeah.
Where 5% where? Because if ultrasound detects 30%,
yeah,
and actual figure is 5%, but ultrasound picks up 40% of the population. So if 5% is the true picture, then you have 200% of the population.
Yes, sir.
So what does that 5% mean? That is a very basic question. And you see, like Dr. Govind was talking about diet, that wheat is bad, start eating rice.
Yes,
now,
sir.
rice you think is bad. So what does patient eat? Govind says you don't eat anything.
No, we are the Asian, in this Asian subpopulation.
But it's the same community in Asia, Bangladesh, Nepal, China, India. See, he says you don't eat wheat, you take rice. If you take rice, you become fat. If you take wheat, you become. What do we eat then?
We the Asian peoples are fond of rice, and we are taking the most of the calorie from the rice. We are inhibiting not more than 900 kilocalorie per day from rice. Will not take more than 900 kilocalorie per day. We should eat rice, but there should be some limitation, and the calorie limit must be below 900.
Can I ask a question to Dr. Anil Arora? Sir, since PCABs are already launched in India and you most probably have been using them, and I think very soon we'll have them in Nepal as well.
Yeah.
So in patients with GERD who fail PPIs, do you give a trial of PCAB? Are they better or
Absolutely. In fact, if you see, that is a totally different topic. One can have a 1 hour discussion on the new upcoming acid suppressants, which is called PCAB, potassium channel acid blockers. And they give you 30% more acid suppressants than the conventional PPI. So in refractory PPI, you have to try PCABs. If that fails, then you go on to endotherapy. That is a good suggestion. And currently available PCABs have the advantage that rather than using twice a daily dose of PPIs, you have to give it once a day. Plus, you don't need to be giving it fasting. You can take it on empty stomach. But since they are not being metabolized by CYP450 cytochrome metabolic pathways, so they do not have interaction with clopidogrel. So these are the 4 advantages. Rapidity of onset, you don't need to be taking fasting. You have to give it a single dose, and they have 30% more acid suppression. So that is a good suggestion.
Thank you, sir.
Again, a question to Dr. Arora. So sometimes when you do endoscopy, the patient is retching. We do it in conscious patients here. So when there is a reflux or let's say prolapse of gastric mucosa in the esophagus, do we label it as weak lower
I think a very relevant question. Whenever you try to make a diagnosis of the reflux on endoscopic examination, be sure that the patient is comfortable not retching. Because prolapsing of the gastric mucosa may be a physiological reflux if the patient is having severe retching. So when you go and look for evidence of Hill grades of the LES relaxation and pathicity, then you have to make the patient comfortable. If need be, give a bit of sedation so that the patient is comfortable, and inflate the stomach and wait for at least 60 seconds for the stomach to get inflated. Because if you decompress the stomach because the patient is retching, you think you are bloating up the tummy, you suck out the air and the LES will collapse. You will never know the degree of dysfunction. Even hiatus hernia can be missed if you keep on suctioning the air. So go in the stomach, put in a lot of air, make the patient comfortable with bit of sedation. And after 90 seconds, you will have a true picture in which you have a immobile gastroesophageal junction. That is the time you make a diagnosis. During retching, you will have a false sense of prolapsing gastropathy being wrongly and mistakenly labeled as reflux esophagitis or hiatus hernia. And then I think surest way of diagnosing hiatus hernia is by doing a good quality endoscopy in which you go and see the 2 things. One is the squamocolumnar junction, that is a salmon and the pink mucosa. And secondly, you also see a diaphragmatic impression. So diaphragmatic impression will be seen as a ring. Squamocolumnar junction will be seen as an area of distinct color of squamous and columnar epithelium. And you see the ascending gastric folds. The top of the ascending gastric fold is the true squamocolumnar junction. Diaphragmatic indentation and top of the ascending gastric fold, where the gastric fold will end. If that distance is more than 2 centimeters, that is the only way to say you have hiatus hernia. Short of that, you don't have hiatus hernia.
Right, sir.
So the 3 things you have to do.
So second, sir, for ARMA, almost all your patients are symptomless, or some of them have relapsed, sir, out of the 100 ARMA?
After?
The 100 ARMA cases which you have
Yes.
done. So any relapses or...
We have been doing it for 2 to 3 years. Not all of them are free of PPIs, but their need for PPI goes down substantially. So as I said, reflux is a combination of so many things.
Yes.
Lifestyle changes, your reduction of the weight, stopping alcohol, stopping smoking, that also contributes. So majority of them are satisfied with a smaller dose of PPIs. So I do not have a data how many we have discontinued totally.
Thank you, sir.
I have a question, the very nice talk, and this post-poem, the patient has developed the gastroesophageal reflux. That we have seen in the Pune, that he is doing that is a poem along with this fundoplication. Why is it recommended in all the poem that the fundoplication is necessary?
I have already stated in my talk that we have done around 600 poems. If you see all those who are doing a good number of the poem, symptomatic reflux is not common. It's not seen in more than 5% of the patient. Whatever data is being quoted repeatedly, it is on parametric assessment of the reflux in the form of pH monitoring study or acid exposure time of 4%. How does it matter? You see, if I do pH study of all gastroenterologists sitting here, 30% may have pH of more than, less than 4, more than 4% of the time. But if they do not have reflux or they have no symptom, why should I keep chasing? Symptomatic reflux is what needs to be treated. That is to the tune of about 5%. In that subgroup, you can, in addition, do a poem F, or now you can do an ARMA, which is much simpler. That is a complicated procedure, which very few people have done it. This was started by Dr. Amol Bapai when we didn't have a long-term data. And most of the people were afraid of having reflux. But nowadays, routinely, nobody is doing poem F. Only if you have symptoms, you treat reflux. Only if you have a symptom which is not responding to medical therapy, including PCAPs, then you switch on to ARMA. So poem F is hardly ever needed now.
So the patient might have a reflux.
No, once you have achalasia, you will not have reflux. It is a tight thing.
Yeah.
There is no need of, because you cannot do a pH monitoring in a tight LES. Yeah. So pH monitoring should not be done before poem, because there is a tight junction, nothing will come up.
Okay, thank you.
Thank you, sir. Thank you all international speakers for insightful talk. Thank you.
Thank you so much, the chairpersons and the very eminent speakers of the session. Now I request the chairpersons to provide a token of love to our speakers. I request Dr. Bhupendra Kumar Basnet and Dr. Pradeep Baidis to provide token of love to Dr. Anil Arora. I request Dr. Khushbu Priya Mishra and Dr. Nikesh Mani Shrestha to provide token of love to Dr. Muhammad Saiful Islam.
Thank you all for your patience. Now the next session is the potpourri session, our last session for today's event. I would like to request the chairpersons, Dr. Dilip Neupane, Dr. Yuvraj Bhusal, Dr. Ajit Khanal, Dr. Manoj Lamsal to chair this session.
So this is the last lot of today, the last session. So now I'm inviting my good friend, Dr. Achalasia, to present on dietary advice in irritable bowel syndrome, a very relevant topic.
Thank you. First of all, I would like to thank the organizing committee for inviting me in this wonderful conference. The topic I am presenting today is dietary advice related to irritable bowel syndrome. Whenever we are sitting in the OPD, after taking the history examination, and once you start writing prescription, the most common question asked by our patient, that also in the OPD, OPD is khana ke barne, because most of our patients are more concerned about what not to eat than what to eat. And especially whenever you are dealing with the patient of irritable bowel syndrome, it is very challenging for us to do the dietary advice. And first of all, I'll start with one of the most commonly asked regarding the alcohol. We can see the evidence suggests that it can cause or worsen the IBS symptom, may cause loose stool, abdominal pain, nausea, and indigestion. But the big question is whether the reduction in the dose of quantity of alcohol will relieve the symptom or not. If you look at this article, this suggests that there is a strongest association for IBS patient between the binge drinking and the next day GI symptom in the form of diarrhea, maybe nausea, or some sort of abdominal pain. Whereas if there is a moderate to light drinking, either may not or weakly associated with the GI symptom. Similarly, in caffeine, which may cause or worsen the symptom, if somebody is consuming more than 400 milligram of caffeine per day, it's worth to reduce the dose of caffeine. Roughly 4 cups of brewed coffee contains 400 milligram of caffeine. This is the recent review articles published that it suggests there is a strong association between the coffee in which the symptom occur very early, like maybe after 1 to 2 hours postprandially. And in case of alcohol beverage, the symptom may occur at 4 to 72 hours. And if you are consuming artificial sweeteners, the symptom may be delayed up to 72 hours itself. Spicy foods, most of us are fond of, and most of the patients here are fond of spicy food. It also may cause symptom, can cause abdominal pain, loose stool, or the reflux. High fat food, also this reduction in fat intake may be beneficial in relieving the symptom. And it is particularly relevant if symptom of abdominal pain or discomfort is occurring after the eating. The next is the lifestyle, which is very important in the management of the irritable bowel syndrome. We are in the age of technology. We know this technology continues to improve the communication, but it has lots of disadvantages. Like you can see in this cartoon that father talking in a mobile, mother with a laptop, and some kids using some kind of gadgets, which is completely unacceptable for this gut health. And there has to be an end of stress zone during some of the time of dietary in the dining table. And there has to be some device-free zone during the certain time, like in the dining table, whenever you are having the food. And always advise the patient to have the proper breakfast, lunch, and dinner with some snacks in between. And always we need to consider and tell the patient about to eat mindfully, sit down for the meal, eat slowly, and always try to avoid the distraction like using the digital screens, and always ask the patient for enjoy their meal. The next is the milk and the milk product. So is it, we need to ask for complete dairy-free diet, or is it only a low lactose diet? Whenever possible, always ask the patient for low lactose diet, not a dairy-free diet. That means, but unfortunately in our market or like Kathmandu, we don't get much of the low lactose diet component and the milk available here. And it is more relevant if the IBS is diarrhea predominant and somebody is suffering from the gastroenteritis. Calcium, if you are replacing the lactose-free alternative, consuming the same amount of calcium. However, if somebody is struggling to use the sufficient alternative, the guideline says to recommend the calcium supplement as well. The next is the gluten-free diet. We know it is found in the wheat, barley, and rye, but in actual saying, this gluten has nothing to do with IBS. It also contains the fructan, which is fermentable in the gut, and everyone has no ability to break them down in the small intestine. And this fermentation of fructan can cause the IBS symptom in sensitive individuals. So for any IBS patient, fructan in wheat is responsible, not the gluten in the wheat. These are the foods to be avoided which are higher in fructan. So if there is a association between the fructan food and the symptom, we should have the 2 weeks reduced fructan diet and has to be replaced with alternative carbohydrate. Can use the gluten-free food. If there is a improvement, no improvement, stop the diet. And if there is improvement, reintroduce the food as tolerated. The most relevant in treating the IBS patient is not a dairy-free or the complete gluten-free, it's a low lactose or a low fructan diet. So next is the FODMAP diet, which is the second line dietary advice to be given in the patient of irritable bowel syndrome. These are the classification according to the food. This is a comparison slide with the high FODMAP and the low FODMAP diet. As I have said, it is the second line dietary advice most of the time. It has to be done with the fully motivated patient in a selected patient and where the dietitian facilities are available. And the restriction phase has to be there for 4 to 6 weeks with reintroduction after 6 to 8 weeks and personalization of the diet as required. This effectively reduces IBS symptom and provides better gastrointestinal comfort and the stool consistency. The next is most of our patients ask about the food allergy. We know food allergy involves the immune system and we know also the IBS has not much about involved the immune system. Therefore, the allergic testing is of no use in case of IBS. The next is probiotic, which is also confusing most of the time, and it shows there is some benefit in the IBS as a whole, but the individual species, strain, or what dose for what duration still remain unknown. And if you are using probiotics, always use the one product at a time for at least 4 weeks and monitor the effect. And if within the 4 weeks treatment, if proves to be a beneficial, administration may be continued. Still, the long-term effects are not known. This is a review article which suggests there is some benefit in IBS patient by slowing down the transit time and improving the stool consistency. Above all, whoever are using this probiotic had good quality of life as compared to other not using the probiotic. So what should be our approach whenever we see the patient of IBS? And the dietary advice should be, first of all, always look for the intake of alcohol, caffeine, spicy food, and high-fat food. Ask the patient to sit down to eat, relax, enjoy their food properly, and have a digital-free zone for the meal. Low lactose diet for 2 weeks if there is an association between the milk products and the symptom. Low fructan diet for 2 weeks if association between the fructan and the symptoms. If there is an improvement, start slowly to reintroduce the small amount and keep that food in a level at the level of tolerance. The most important part I want to highlight is none of these dietary approaches are for life. And always challenge regularly with a food to determine if the tolerance has improved or not. And remove the food groups for a limited period of time of 2 weeks, and if there is no improvement, reintroduce that food back to the diet immediately. And it has nothing to do with food allergy. Low FODMAP diet may be useful, but under the guidance of dietitian itself. All diets are useful in both the diarrhea or the constipation predominant IBS. Always ensure to increase the non-caffeinated fluid intake up to 1.5 to 2 liters if constipated. And finally, I want to conclude with some of the do's and don'ts related to dietary advice, like always monitor the trigger food, eat mindfully, may try probiotic, follow a low lactose diet if needed, consider low FODMAP diet, stay hydrated, reintroduce the food gradually, and exercise regularly, manage stress, and get enough sleep. And don't overconsume alcohol, caffeine, don't eat quickly or skip the meals, that can also precipitate, and cut down the dairy product without any reason. Don't cut down the dairy product, and don't follow a restrictive diet indefinitely, and don't stress too much about the diet. And finally, I want to conclude that avoid the extreme diets, and the balance is the key. Thank you very much.
Thank you. That was an excellent talk. Now, without delay, I would like to welcome Ms. Deepshika Niraula on the topic endoscopic cleaning and the reprocessing.
Good evening, everyone. First of all, I want to thank the organizing committee for providing me this opportunity. My topic today is manual reprocessing of flexible endoscope. It is not often highlighted, but it is very important to ensure patient health and instrument safety. GI endoscope are widely used diagnostic and therapeutic purpose. It contains high level of microbial contamination during each use. It ranges more than 10 to the power 5 colony forming unit per ml during each use. And inadequate manual reprocessing can act as point source of infection. According to CDC, about 70% of endoscope related infection were due to inadequate manual reprocessing. Flexible endoscopes are classified as semi-critical instrument, and it should go high-level disinfection. Many multinational organizations approved standard manual protocols and disinfection solution and enzymatic solution also. There are repeated incidents of multi-drug resistant microorganism outbreak globally. The notable incident was in 2015 outbreak, where there was CRE outbreak in US. It was also due to improper cleaning in all-barren channel of duodenoscope. There are few disinfectants that are standardized by multinational organizations. Some of the common disinfectants are glutaraldehyde 2.3% with contact time of 20 minutes, orthophyllaldehyde 0.55% with contact time of 12 minutes. And always follow manufacturer protocol before each use. There are two methods for reprocessing of endoscope. First one is manual reprocessing, second was automated disinfecting machine. I am today focusing on manual reprocessing because every institute may not have automated reprocessors. So there are 7 steps for manual reprocessing of endoscopes. Pre-cleaning should be done immediately after procedure in. It is said that it should be done within 1 hour of completion of procedure. Endoscope is wiped with disposable cloth that is soaked with enzymatic solution, and then air water ventiles should be replaced with air water cleaning ventiles and suction for at least 10 seconds. And transfer the endoscope in cleaning room safely. Connect leak tester in cleaning room. At first connect leak tester and then check if there is any leak positive of endoscope or not. Leak tester should be connected before immersing in enzymatic solution. It detects the damage to interior and exterior of endoscope. If there is any leak positive, then we should not continue disinfecting the endoscope. It should be sent to maintenance unit immediately. If there is no any leak positive, then we should continue the cleaning. Make of enzymatic solution as recommended by multinational organization. It should contain at least combination of proteinase, amylase and lipase. Make of fresh enzymatic solution 1.5% and then immerse the instrument completely. Then disconnect all the ventiles from scopes and wipe exterior part of endoscope and then brush all the channel accessories and ventiles also. We should always use compatible size to brush the endoscope and attach cleaning adapter and floss all the channel, at least 60 ml for diagnostic flexible endoscope. Cleaning of enzymatic solution should be done by followed with air flossing also. And then before immersing in high level disinfection solution, we should rinse with tap water because it can interfere with solution concentration. Rinse outer and inner surface of endoscope. Floss tap water into endoscope completely and then followed with air flossing. For manual high level disinfection, immerse completely into disinfection solution, inject solution into all channels and ventiles, and floss disinfecting solution into accessories also. You should also leave endoscope into disinfection solution according to company protocol, and after completion of disinfection, then floss with air because to preserve the concentration and volume of solution. Final rinsing should be done with tap water, either with tap water or distilled water. It is not recommended to use distilled water. Immerse the endoscope and accessories and ventiles completely into distilled water and then floss all the lumen and channel to remove all the traces of solution. Do not forget to clean exterior surface of endoscope also. And after doing rinsing with distilled water, floss all the channel with 70 to 90% of alcohol and dry all the channels, valve and accessories. If available, then use air dryer. If not available, then you can also do manual air flossing with syringe also. Do not use high air pressure because it can damage the interior surface of endoscope. And for storage of endoscope, always use well-ventilated cabinet. The scope should be hang vertically without any ventiles. The cupboard should be washable and it should be washed at least weekly. What we have done should always be documented. So document about clean scopes and either faulty scope that is reported during cleaning or during procedure. For quality assurance, check periodically, at least once a year, and collect sterile sample for. There are many challenges to achieve infection prevention in endoscopy unit. First one is we always want to do shortcut method because of overload of work. So it should not be done. if there is already some infection of or contamination in endoscopy unit, such as contamination in water supply in endoscopy unit, or there was already biofilm formation in endoscope, then it should be also considered. Okay, for summary, there are 7 steps for manual reprocessing. We should do all the steps properly, and for brushing it is recommended to do 3 times of brushing to the channel, because it is said that 40% of debris can be removed in 1 time of brushing. Thank you so much.
Thank you, Ms. Deepsika Nirola. It was an elaborating talk on endoscope cleaning and reprocessing. So moving on to our next topic on potpourri session, I would like to introduce Dr. Ramkrishna Baral, who will be enlightening us with submucosal injection agents and technique. So welcome, Dr. Ramkrishna Baral.
Good evening. Thank you, organizers, for giving me this opportunity to speak. And my topic of presentation is submucosal injection agents and technique. Regarding the introduction, GI tract cancer is one of the most malignant tumors with high morbidity and mortality, and it is the second leading cause of cancer-related death worldwide. And early detection and treatment of potentially curable cancer and precancerous lesion, which reduce of GI cancer incidence as well as mortality. And during the past decade, endoscopic resection techniques have gradually improved and gained more importance in the management of pre-malignant lesion and early cancer of the gastrointestinal tract. An injection-assisted EMR was first introduced in 1955 for rigid sigmoidoscopy, and then in 1973 for flexible colonoscopy. And ESD has been developed allowing en bloc resection for superficial neoplasm and providing better histopathological diagnosis and a decreased local recurrence rate. So the question arises, why we need submucosal injection? Because submucosal injection, it provides a lifting up effect of the lesion, which separates it from the muscular layer. It also decreases the risk of thermal injury, also reduces the risk of perforation and bleeding, and it facilitates en bloc resection by improving technical feasibility. An additional important aspect is that if dyes are incorporated with the submucosal injection, lesions margins are clearly defined, and especially especially in the colon. Before injecting the submucosal injection, we have procedural planning. Given the increasing risks of lymph node metastasis associated with deeper tumor invasion into the wall, determination of the depth of the lesion is important before the endoscopic resection. And we can do it by analysis of during endoscopy the lesion, feature of the lesion, as well as pre-endoscopic resection EUS. And certain lesion characteristics detectable on endoscopy have been associated with submucosal invasion, like depression of the lesion, Paris type 2C. The size of the lesion is more than 15 mm. Failure to lift with submucosal injection, smooth non-indented circumference of elevated Paris 2A or depressed 2C lesions. As you know that there are 5 layers of GI tract by US. The innermost layer is the mucosal layer, which is hyperechoic on US. Subsequent layer is muscularis mucosa, which is hypoechoic, followed by submucosa, which is again hyperechoic. Then muscularis propria, hypoechoic, then serosa, hyperechoic. So endoscopic resection, there are three methods by which we can do endoscopic resection. One is snare polypectomy, another one is endoscopic mucosal resection, EMR, and another one is endoscopic submucosal dissection, ESD. In polypectomy, we only need snare, but not submucosal injection. Whereas in EMR and ESD, we need submucosal injection to lift the lesion. And the intended plane of resection is mucosa in case of snare polypectomy, whereas the intended plane of resection is submucosa in case of EMR and ESD. So the question arises, what is the ideal injection solution? The ideal injection solution should provide a thick submucosal fluid cushion that remains in the submucosal space long enough of time, and it should be inexpensive, widely available, improves the outcome of the procedure, reduce adverse events, and should not damage tissue specimen for the accurate pathological staging. And there are various submucosal injection solution to choose, but there is no consensus yet which one is the best. Some solutions are easily available with low of cost, and some injection solutions are not easily available and they are high of cost, and some may cause the tissue damage, and some may cause risks of antigenic reactions. So, normosaline, it is commonly used submucosal injection. It is safe to use, low of cost, and easy to use with negligible, no potential toxic effect or damage to tissue specimen. And the major limitation of the normosaline is it rapidly absorbs into the surrounding tissue, which reduces the duration of a proper submucosal cushion. But this major limitation is not important for the lesion less than 20 mm of size, and this normosaline increases procedure time in larger lesion or longer procedure time. Another one is glycerol. It is a hypertonic solution consisting of 10% glycerin and 5% fructose in an normosaline solution. Has been used intravenously to treat cerebral edema with no toxic systemic effect. And in 2005, Urawa et al. Examined clinically the efficacy of glycerol as a submucosal solution during EMR, and it was shown to safely increase en bloc resection in his study. So here we can see the normosaline versus glycerol and the duration of the submucosal elevation in the submucosal elevation, which is clinically significant in favor of glycerol. Similarly, regarding the en bloc resection, the lesion up to 10 to 19 mm, the glycerol arms, they have 85.9% of en bloc resection, whereas in 66.7% only in NS arm. And the larger lesions like 20 to 29 mm, the en bloc resection rate was 23.1% in glycerol, whereas only 20.5% in normosaline arm. Another one is hyaluronic acid. It is a type of glycosaminoglycan found in connective tissue, high viscosity and water retention capability without being antigenic or toxic. And its approved indication is intraarticular injection for osteoarthritis and eye surgery. And 0.4% of solution of hyaluronic acid has been approved for commercially used as submucosal solution in Japan. And it provides the longest lasting fluid cushion and higher success en bloc resection and lower perforation complication rates, and consider best agent for submucosal injection. However, its disadvantages are high cost and unavailability, and considered suitable for ESD because of its higher en bloc resection rate. Another solution is Eleview or Oris gel. LAView synthetic solution supplied in 10 ml ready-to-use ampoules, and it composed of water, sodium chloride, poloxamer 188, polyoxal 15 hydroxyesterase, medium chain triglycerides, and it provides an immediate and long-lasting cushion beneath the polyp and improving the visibility of this lesion due to methylene blue. And when compared to normal saline, the LAView has demonstrated better cushion forming ability and a duration of lift up to 45 minutes. And it is very expensive and for routine use. Another one is Origel. Similar solution for other manufacturer, Boston Scientific, is also available, showing comparable results with former and received FDA approval. Another one is novel submucosal injection materials, Puralift. So fully synthetic and self-assembling peptide solution for submucosal injection material is a non-biological preparation that self-assembles to create a gel of nanofibers when in contact with neutral pH, and it contains the same ingredients as the peptide hemostatic agent, Purastat. Regarding the adjuvants aid endoscopic resection and to reduce the complication rate. Diluted epinephrine and staining dye like diluted indigo caramine and methylene blue are the adjuvants. Regarding the epinephrine, we are using the diluted epinephrine of strength 1:50,000 to 1:2 lakh, which aided the submucosal injection, has a theoretical benefit of decreased bleeding and sustained submucosal cushion and is generally safe. Unlike higher dose of 1:10,000 dilution, which has the complication of severe hypertension, VT, and intestinal ischemia, the diluted epinephrine has less of such events. And ESC guideline recommend the use of diluted epinephrine before hot snare polypectomy of large perineal polyp, head size of more than 20 and stuck width of more than 10 mm. And a recent meta-analysis showed that submucosal epinephrine injection before resecting larger polyps of size more than 20 mm decrease early post-polypectomy bleeding, but not the risk of delayed post-polypectomy bleeding. Staining dye, commonly used are diluted indigo caramine and methylene blue. They help identifying the area of submucosal injection and clearly distinguish between the muscle layer and the submucosal layer. They facilitate identification of the lateral and deep margin of the target lesion before and during the resection process. They help to evaluate the presence of residual lesion at the end of endoscopic resection and improve recognition of intraprocedural perforation. And the ESC guidelines recommend that biological inert blue dye should be incorporated into submucosal injection solution to facilitate identification of fluid cushion extent, lesion margins, and deep mural injury when performing EMR of target lesion more than 20 mm or LST. The addition of staining dye in submucosal injection is mandatory when performing ESD. And regarding how to inject, carefully evaluate the lesion features and location before the injection. An en bloc EMR of a smaller lesion, single cushion with an injection point center in the lesion can be best option. And removal of large lesion by piecemeal EMR, more than one injection needed to lift the entire lesion and to maintain the submucosal cushion during the whole procedure. And puncture and injection of at the border of the previous submucosal cushion can facilitate access to the submucosal space and expand the cushion laterally. And dynamic submucosal injection technique, which allows submucosal injection position and shape adjustment during injection, and it improves the feasibility of EMR. During ESD of a small gastric lesion, the operator can inject all around the circumference in order to perform circumferential dissection without changing the instrument. And larger gastric lesions or lesions in difficult location and also in colonic ESD, semi-radial injection can be preferred, and subsequent injections should be performed at lateral margin of the previous injection. And after circumferential dissection, injection should target the submucosa below the lesion. This can be achieved by placing the injection needle right below the lesion margin, directly targeting the remaining submucosal space by slightly lifting of the needle. Thank you.
Thank you, Dr. Baral, for putting the summary of a very useful topic. So now I'd like to welcome Dr. Ajit Thapa from Tribhuvan University Teaching Hospital. He will be explaining on arterial GI bleeds and role of interventional radiology. The floor is yours, Dr. Thapa.
Good evening. So, first of all, I'd like to thank the organizing committee, Bir Gastro department, for inviting me to speak on this topic, arterial GI bleed. Respected chairperson, distinguished guest. So, without a delay, I would like to start my talk on arterial GI bleed, role of interventional radiology or non-variceal GI bleed. So I don't have any financial disclosures to make. GI bleed is really pain. If it is upper GI, endoscopist and gastroenterologist, they are doing good. But if it is lower GI bleed, then the diagnosis and management is challenging. So bleeding proximal to the ligament of crease is upper GI, and bleeding distal to it is lower GI. So lower GI is less common, but it's difficult to manage. Because GI bleed is intermittent, and since it is intermittent, it's difficult to diagnose when there is no bleed. It contributes to the patient morbidity and mortality. Also, the anatomy of the GI tract, like celiac trunk, SMA, and IMA, they supply the gut. This leads to good collateral supply, for which, like, if we do embolization, then collateral can handle the ischemia, but also at the same time, the bleeding can occur or rebleed can occur. So there are different causes of upper GI and lower GI bleeds. So here are the things. So in diagnostic imaging, there is technetium RBC scan. It has good sensitivity and specificity, but the localization, false localization is high, that is 22%. And if you see CT angiography, when the patient is bleeding, then the detection is high, but there is a spasm or hemostasis is there, then we cannot identify bleeding. And there is no therapeutic role of CT angiography, but it also helps to identify the arterial source to plan interventional radiology or surgery. Regarding transcatheter angiography, if bleeding is more than 1 ml per minute, we can detect it when patient is bleeding. So there are different signs in transcatheter angiography after which we can embolize the artery. So challenges is peristalsis, respiration, due to which the location changes, and also intermittent bleeding, as I said. So there is a thing called SOC index, and if it is more than 1, then the chances of detecting bleeding in CT angiography or invasive angiography is higher. So also, British Society of Gastroenterology has recommended doing, in case of lower GI bleed, recommended doing CT angiography after initial resuscitation of the patient if the SOC index is more than 1. So where IR stands in management of non-variceal bleed? In case of upper GI, we have very little role. If patient rebleeds after endoscopic management, then again endoscopic management. But the second line of therapy is transarterial embolization. And in case of lower GI bleed, this is the British Society of Gastroenterology guideline, which has clearly said to do CT angiography if the SOC index is more than 1. And the lesion can be treated either by IR or endoscopically, whichever facility is available. And if one fails, then another treatment options is there. So what IR can offer? Diagnostic catheter angiography. We can also provocate bleeding if there is a spasm or hemostasis, but it is slightly risky. Vasopressin injection, it was in older days where the embolization was not advanced. But now we have transarterial embolization where we do super selective embolization of the target bleeding vessels. Preserve adequate blood supply from the collaterals. And the success rate on average is 70 to 80%. We have different embolizing agents like microcoils, PVA, gel foam, or glue. So this finished my reading part now. I'll be showing some spectrum of cases, starting from the stomach up to the anal canal, where bleeding was there, and then it was referred from the gastroenterologist and surgeons for the management. This is the first case where it is a case of stomach cancer on chemotherapy, and it was bleeding. Probably it was not arterial, but parenchymal bleed. So we embolized the left gastric artery to achieve hemostasis. Second case, pancreatitis patient in which left gastric artery was bleeding, and you can see a pseudoaneurysm here. And this is a yin-yang sign which says it's a pseudoaneurysm. So initially we tried to cannulate the left gastric artery, which failed. So we directly punctured the pseudoaneurysm and injected glue in this, and you can see there is no more flow in the pseudoaneurysm. So this is another case in which cystogastrostomy was done, and there was blood in the stomach. So on CT scan, we could see a small left gastric artery branch. On invasive angiography, we cannulated the left gastric artery. We crossed the back door. In GI, since it is rich in collaterals, we have to cross the back door and embolize the back door as well as the front door to achieve complete hemostasis. So you can see we have deployed one coil beyond the leakage, and then another coil in the proximal part of the leakage. This is another interesting case in which case of pancreatitis, we embolized already once. Few days hemostasis was there, but again he started bleeding. So there in CT angiography, you can see these are coils, and this is blush of contrast into the duodenum. And we did angiography again, and we can see a blush of contrast here. Again, we embolized with multiple coils. This is the second session. But again, he bled. So this time, what we did was we directly accessed the pseudoaneurysm and then injected glue in it. Finally, he got relieved of bleeding. Another case in which there is hepatic artery pseudoaneurysm, it is compressing bile duct, and then there was obstructive jaundice as well as GI bleed. So again, we cannulated the feeder and then coiled and then injected glue to thrombose the pseudoaneurysm. Again, most of the GI bleed in which endoscopists refer is pancreatitis bleeding. So this is, again, on endoscopy there was bleeding from the papilla. So this is a case of Haemosuchus pancreatiticus. On CT scan, there is a pseudoaneurysm in the splenic artery. Probably this blood went into the main pancreatic duct, and then it was coming out of the papilla. So we again embolized the back door and front door of the splenic artery pseudoaneurysm. This one is obscure bleeding. In endoscopy, there was diverticulum. Also in CT scan, there was diverticulum, and some blood was coming out of the diverticulum. So we did angiography, and of SMA angiography, IPDA was identified, and the artery, it was taking shape of the diverticulum. We embolized that. Similarly, you can see in this case, this is also a diverticular bleed. You can see active contrast extravasation into the duodenum. So we embolized and achieved hemostasis. You can see there is a clip kept by endoscopy. This is a case of leukemia in which platelets was low and then he was bleeding. So clinician, they tried to stop the bleeding, but there was oozing from the side of the clip. So this time what we did was we cannulated the artery which was going to the clip and then embolized with the glue. But this patient again came after 3-4 months. Maybe the basic problem was thrombocytopenia, so he keeps on bleeding from different sides. So this is a post-Whipple's case in which there was a GI bleed, and the bleed was from the PJ side. And you can see on angiography there is a contrast intravasation into the small intestine, so which was super selectively cannulated and embolized with a coil. This is a case of RCC which has large mets in the abdomen which eroded into the intestine. So again we embolized the tumor part and the bleeding stopped from into the intestine. Another is angiodysplasia. It's very difficult and challenging even for us if the bleeding is in the jejunum, because the jejunum will contract and it will move in different position. So in CT angiography, you can see dilated vessels in the jejunum. So this is the angiography, and you can see a blast over here. And we have different signs to identify angiodysplasia. One of it is pseudo-vein sign. So you can see contrast blast, and then in which we super selectively cannulated and injected a small amount of glue. And this is the check angio, which is showing no more pseudo-vein sign. This is one of my initial cases. Bhupendra sir is here. He referred like a young male. He was bleeding from the ileocecal region, and he was profusely bleeding, and even in CT scan there was contrast in the ascending colon. So we did angiography of the ileocecal artery, and you can see the contrast. It's going in the ascending colon, and you can see the patterns of ascending colon. So we super selectively embolized the ileocolic artery, and the child did well, and then he was discharged soon. Now moving to the rectum. You can see there is a small pseudoaneurysm from the inferior rectal artery, case of colitis, in which there is a continuous bleeding, and then so we super selectively cannulated the IRA. It is a branch of internal iliac artery, and then we embolized with glue. This is the last one. So hemorrhoids, there is role of IR in which the superior rectal artery is embolized, even if it's not bleeding. But in this case, he was bleeding, so previously we kept 2 coils to reduce the pressure to the hemorrhoids. But after a few days, again, you can see the patient was bleeding, and it was also referred from the surgery people. Patient was in ICU, so you can see jet of contrast going into the rectum. So this is the branch of internal iliac artery. So inferior rectal artery was bleeding, and in which we also super selectively cannulated up to the bleeding site and embolized with glue. So he was moved to ward and then discharged. So in these cases, the follow-up should be done by surgeons or endoscopy, so that the residual disease is there or not. And if we embolize some tumors, if it is emergency, then second look endoscopy or colonoscopy should be there. So this is a picture around 8 years back in Bir Hospital, where we did our first transjugular liver biopsy, and bunch of all residents, enthusiast residents. So this picture I kept here to thank Bir Hospital for giving the opportunity. That day also, in those days, they used to send patient to me, believing in IR, believing in me. So thank you so much.
Thank you so much, Dr. Ozzy Thapa, for a wonderful presentation. And thank you for rescuing the gastroenterologists, gastrosurgeons, as well as saving so many patients. So now I'd like to welcome the next speaker. The last speaker for today's program, and it is quite an interesting and one of the most useful topic. This is legal implications of interventions in gastroenterology. So Dr. Rajiv Rijal, the floor is yours.
Good evening, ladies and gentlemen, our respected chairpersons, distinguished guests, and delegates. I'm going to talk about the legal implications, not only of gastroenterology, it is applied in all medical specialties in context of Nepal, and not only for interventions, not only therapeutic interventions, I'm talking about both the diagnostic and therapeutic part. This is the outline of my presentation. I'm not going into details of medical jurisprudence, as we have well studied it during our MBBS days, but how is medical jurisprudence related to the legal field? The outline is that there are some statutory laws which directly or indirectly guides our practice, and there may not be the direct saying, or there may not be the direct legal consequence that only doctors or medical practitioners are set for these laws. But regarding the second portion, medical laws or ethics, they are directly or indirectly related to us, and they may not be quoted anywhere as law. This thing we have studied very well, and how civil or criminal liability is imposed upon a doctor comes from either professional negligence or infamous conduct in our context. And not only the civil liability, there comes issues of tort. Tort bhaneko duskriti Nepali ma. I'll be speaking in Nepali as well. Duskriti bhaneko chai kasto ta bhandakheri civil liability bhaneko civil law le केही कुरा हामीलाई इम्पोज गर्छ जसको चाहिँ फाइन हरुको माध्यमबाट कम्पेन्सेट हुन्छ. तर टर्ट चाहिँ कस्तो हो त भन्दाखेरि टर्टमा चाहिँ जस्तो टर्टको कमन एकदम क्लासिकल एक्जाम्पल छ, कसैको गाईले चाहिँ गएर कसैको बाली खायो भने त्यहाँ हानि ल्यान्ड ओनरलाई त भयो, तर त्यो बाली द्याट विल ग्रो इन्टु सम हार्भेस्ट लेटर विच इज अल्सो लस्ट. सो कम्पेन्सेसनमा त्यो बाली मात्र होइन, we need to count for that loss पनि, त्यो चाहिँ tort भनेर बुझिन्छ. These are some international instruments which may not be reflected in our law, but whether these things are taken into consideration, भन्दाखेरि चाहिँ yes, they are. So all medicine is made to make you better, but if it did the opposite, it will be malpractice. यो चाहिँ एउटा slogan जस्तरी use गरिएको छ. Talking about Nepalese legal framework, everybody of us know that we have constitution as the ground norm, and then acts, then procedures, rules, regulations, and other substandard things. And talking about which laws guide our medical field, these are some of the laws that guide the medical field. Going on to provisions, the Constitution of Nepal, Fundamental Rights, Article number 35 and 44. These are the two fundamental rights that guide medical field. Now coming down to Muluki Criminal Code, यसलाई चाहिँ मुलुकी अपराध संहिता भनेर चिनिन्छ. हामीले यसमा हेर्यौं भने जस्तो डाइरेक्टली मेडिकल फिल्डमा युज हुने भनेको चाहिँ 230 इजाजत प्राप्त नगरेको व्यक्तिले उपचार गर्न नहुने, इलाज गर्न नहुने. इलाज भन्दा यहाँ डायग्नोस्टिक पार्ट पनि इक्वली इन्भल्भ हुन्छ. त्यसपछि बदनियत चिताई इलाज गर्न नहुने भनेको छ, यो पनि इक्वली इम्पोर्टेन्ट. लापरवाही वा हेल्थ चेक राई यो पनि इक्वली इम्पोर्टेन्ट. These are some lesser important things for us. Coming on to this, we have got statute of limitation, which is very important. I'll come to it further. Coming to recklessness, gambhir laparwahi, and negligence, health check crime. These two things are also very important in our context, which are frequently being taken. So, if we talk about recklessness and negligence, these two things appear to be different, but in law they are taken as quite same. But if we go to the punishment section, there comes a gross difference between them. Now coming on to the consent. Consent is very important as per Nepalese law. Consent चाहिँ जुन हामीले जस्तो consent बुझेको छौं त्यसैलाई consent भन्ने कि consent is some other thing भन्ने पनि एउटा एकदम important issue छ. Like consent दिनलाई at least measure हुनुपर्छ, माइनरले consent दिन पाउँदैन. त्यस्तै चाहिँ जस्तो हामीले not only for physical examination को मात्रै consent लिएर verbal या implied consent ले यदि हामीले चाहिँ उसमा चाहिँ उपचार गरिरहेका छौं, जस्तो हामीले मानौं कि उसको चाहिँ केही हामीले इन्टरभेन्सन या थेराप्युटिक या डायग्नोस्टिक बडीली इन्टरभेन्सन गरिरहेका छौं भने चाहिँ implied या verbal consent cannot be taken as consent. त्यस्तै consent मा चाहिँ if we really fail to get consent and if that goes to court, there is a provision for punishment as well. That is 3 years of imprisonment or 30,000 rupees of fine. So what is compensation according to Nepalese law? हामीले चाहिँ compensation को provision पनि जान्नु पर्ने हुन्छ. Compensation क्षतिपूर्ति, यसमा चाहिँ this somehow it is related to ज्यान सम्बन्धी भन्ने अर्को महल छ अपराध संहितामा नै. यसमा चाहिँ यदि कसैको हाम्रो उपचारको कारण या डायग्नोस्टिक इन्टरभेन्सनको कारण यदि डेथ या चाहिँ ग्रिभियस इन्जुरी भनेको अंगभंग भएमा that counts equivalent to ज्यान सम्बन्धी कसुर. सो यो चाहिँ अलिकति सिरियस छ कम्पेन्सेसन को हिसाबले पनि. Now talking on to Medical Council Act. Medical Council Act मा धेरै कुरा डाक्टरलाई गाइड गर्ने इथिक्स सम्बन्धी छ, तर पनि यसमा पनि केही न केही कुराहरू छ जसले चाहिँ जस्तो क्रिमिनल ल या हाम्रो कोर्ट र क्रिमिनल सिस्टमलाई पनि कतै कतै चाहिँ यसले जोड्न खोजेको जस्तो भन्ने चाहिँ देखिन्छ. यसमा दुईटा मुख्य इम्पोर्टेन्ट कुराहरू चाहिँ जस्तो डिरेजिस्टर गर्ने भनेको प्र्याक्टिसनरलाई डिरेजिस्टर गर्ने त एउटा कमन नै कुरा भइगयो, तर त्यसैमा चाहिँ अर्को जस्तो अपिल मेडिकल काउन्सिलले कुनै डिसिजन गर्यो भने वेयर शुड अ डक्टर or even patient parties go to medical council with their complaints. So where can the suffering party go for appeal? यो एउटा important issue जस्तो देखिन्छ हाम्रो सिस्टममा. किन भन्दाखेरि चाहिँ मेडिकल काउन्सिलको डिसिप्लिनरी कमिटीले लिएको एक्सन को त्यसपछि मेडिकल काउन्सिलकै फुल मेम्बर्समा जाने हो कि हामीले मिनिस्ट्री अफ हेल्थमा जाने हो या चाहिँ फर्दर क्यान वी गो टु द कोर्ट भन्ने कुरा पनि एकदमै कन्फ्युजिङ छ. यसको कुनै क्लियर कट त्यस्तो गाइडलाइन्स छैन. स्टिल हामी कोर्टमा जाने हो भने चाहिँ वी हेभ गट लिमिटेशन्स अफ 35 days. नाउ अनदर इम्पोर्टेन्ट कमिङ अन टु प्रोभिजन्स अन्डर कन्ज्युमर प्रोटेक्सन एक्ट. जसरी डक्टरहरूलाई चाहिँ मेडिकल काउन्सिल एक्टले गाइड गरेको छ भने कन्ज्युमर्सहरू चाहिँ कसरी कुन तरिकाले प्रोसिड गर्ने त भन्दाखेरि चाहिँ वी हेभ गट कन्ज्युमर प्रोटेक्सन एक्ट. कन्ज्युमर प्रोटेक्सन एक्टले चाहिँ सर्भिसेस र गुड्सलाई काउन्ट गर्छ. सर्भिसेस भनेको मेडिकल सर्भिस पनि पर्यो. सो यसको चाहिँ 2 नम्बर प्रोभिजन अर्थात् दफा 2 ले चाहिँ कसरी कन्ज्युमर यदि हाम्रो ट्रिटमेन्ट या थेराप्युटिक प्रोसिजर्स या डायग्नोस्टिक प्रोसिजर्सले कुनै पनि हानि नोक्सानी भएको छ भने हाउ क्यान समबडी सिक फर जस्टिस भन्ने कुरा चाहिँ कन्ज्युमर प्रोटेक्सन एक्टले गाइड गरेको छ. त्यस्तै वी हेभ गट सम अदर रिलेभेन्ट एक्ट्स लाइक एभिडेन्स एक्ट, ब्रिफ प्रोसिजर एक्ट, ड्रग एन्ड रेगुलेसन एक्ट. त्यस्तै चाहिँ पब्लिक हेल्थ सर्भिस एक्ट छ, नेपाल हेल्थ रिसर्च काउन्सिल एक्ट, चिल्ड्रेन एक्ट, नर्सिङ काउन्सिल एक्ट, हेल्थ प्रोफेसनल काउन्सिल एक्ट, हेल्थ सर्भिसेस एक्ट एन्ड रेगुलेसन्स, ह्युमन अर्गन ट्रान्सप्लान्ट एक्ट, फार्मेसी काउन्सिल एक्ट, सेफ मदरहुड एन्ड रिप्रोडक्टिभ हेल्थ राइट एक्ट. यस्तै वी हेभ सो मेनी डिफरेन्ट एक्ट्स विच गाइड मेडिकल प्र्याक्टिस इन नेपाल. Now I am talking about some landmark cases decided by Supreme Court. What was the verdict given in these cases are very important. यो एउटा केसमा चाहिँ जनहित संरक्षण मञ्च भर्सेस दिनेश विक्रम शाह, डाक्टर दिनेश विक्रम शाहको केसमा लिमिटेसन, अघि मैले भनेको थिएँ स्ट्याच्युट्स अफ लिमिटेसन इज भेरी इम्पोर्टेन्ट। यसमा चाहिँ कस्तो छ त भन्दाखेरि लिमिटेसन सुड नट बी क्यालकुलेटेड फ्रम द डे अफ प्रेस्क्रिप्सन, यो एउटा इम्पोर्टेन्ट फाइन्डिङ छ। त्यस्तै अर्को सुषमा थापाको केसमा चाहिँ मेडिकल केयर बिजनेस या एक हिसाबले चाहिँ क्वालिटी अफ सर्भिसेससँग पनि रिलेटेड भएको भएर चाहिँ हामीले अर्थात् कोर्टले चाहिँ सुप्रिम कोर्टले डक्टर पेसेन्ट रिलेसनसिपलाई चाहिँ एउटा भगवान र भक्तको रिलेसनसिप भन्दा पनि अलिकति फरक तरिकाले लिएको छ। त्यस्तै अर्को रजिया खातुनको केसमा पनि राइट टु हेल्थ एन्ड राइट टु लिभ विथ डिग्निटी चाहिँ मेडिकल ट्रिटमेन्टसँग पनि जोडिएर आउँछ भन्ने कुरा चाहिँ सर्वोच्च अदालतले नजिर प्रतिपादन गरेको छ। त्यस्तै यो अर्को केसमा पनि ज्योति बानियाको केसमा मेडिकल एक्जामिनेसन्स पनि नेग्लिजेन्ट भयो भने चाहिँ द्याट वाज डिम्ड टु बी माल प्र्याक्टिस। सो द फाइनल टेक होम मेसेज विथ दिस डिस्कसन इज द्याट डक्टर पेसेन्ट रिलेसनसिप भनेको चाहिँ एउटा प्रोफेसनल मात्रै होइन, लिगल रिलेसनसिप पनि हो। डकुमेन्टेसन सबै स्टेपमा हुनुपर्छ, जसको कुनै पनि सर्टकट भन्ने कुरा छैन। त्यस्तै कन्सेन्ट इज अ टु साइडेड सर्ट, कन्सेन्टले बचाउँछ पनि बिगार्छ पनि। र हामीसँग भएका लज एन्ड रेगुलेसन्स भनेको चाहिँ दुवै पार्टीलाई अर्थात् डक्टरको पार्टमा र बिरामीको पनि पार्टमा दुवै पार्टको लागि चाहिँ बनाइएका हुन्छन् भन्ने चाहिँ बुझ्नुपर्ने जरुरी देखिन्छ। एन्ड थ्याङ्क यू भेरी मच।
So this is the final session. Now the floor is open for question and answers. So first of all, I would like to start with a question myself. This question goes to Dr. Rajiv Bijal. सर त्यहाँबाट भन्नुभयो नि हुन्छ सर, हामीले चाहिँ कुनै प्रोसिडर गर्नलाई आज हामीले कन्सेन्ट लिएको छौँ, तर त्यो प्रोसिडर हामीले इफ यु डु द प्रोसिडर द नेक्स्ट डे, सो विल द्याट कन्सेन्ट बी भ्यालिड अर नट?
पोस्टपोन गर्नुपर्ने कारण के थियो त्यो कुरा यदि त्यही कन्सेन्टमा हामीले एड गरेर अनि फेरि रिसाइन गर्यौँ भने द्याट कन्सेन्ट विल बी भ्यालिड।
Okay. Okay.
Who had presented on endoscopic disinfection. How many infections occur with routine endoscopy and colonoscopy? Is she there? Anybody can answer on her behalf. And ERCP is, it is understandable, cystogastrostomy, ERCP calling that is. But with the routine endoscope and colonoscope, do the infections occur?
There are many incidents reported of H. pylori transmission also globally. But in our setting, we are doing periodically microexamination. So it is not reported in our setting till now. But globally, we can see that there are many incidents of H. pylori pseudomonas infection.
We have a large gathering of gastroenterologists here. Anybody seen any infection occurring because of your endoscopy, upper GI or colon? There is no doubt it should be cleaned. It should be. And how much time does it take to do everything which you have recommended?
We can immerse into the solution according to protocol. So if you use orthophaladiide, it takes 30 minutes, 20 to 30 minutes around here.
All 7 steps?
Yes, sir.
And is there a quality assurance? Because in busy practice with sick patient coming and going? How many are able to stick to that? Does anybody third party monitor?
We set the timer for complete immersion in the solution, sir.
Well, you see, the type of workload people have and the limited number of the dedicated people, everybody will not have Deepshikha. There will be only one Deepshikha in Kathmandu. But what happens at other centers?
Yes, sir. We have to balance between our protocol and cases, of course. Thank you, sir.
Sir, I have a question for Ajit. I have a few simple questions actually. So, there are most of your patients who bleed are sick, and do you consider any platelet counts or coagulation profile before intervening? Number one. Number two, a lot of endoscopic ampulectomy are being done these days, and sometimes very bad bleeding occurs. And is it possible or is it practical to go for preemptive blockade of the involved vessel preoperatively?
Thank you for the question. First of all, if platelet count is low, so generally we consider 50,000 platelet and INR more than less than 1.5. So if it is there, we are safe. But if coagulopathy is there and if patient is dying, then we have to take high risk consent for that, because we will puncture the femoral artery and next day what happens, there is femoral pseudoaneurysm or patient is bleeding from the thigh. So high risk consent should be there. Patients should or relatives should understand why we are doing the procedure. Regarding preemptive embolization, I think like we shouldn't do that, because embolization itself has risk of bleeding, contrast allergy, and then also non-target embolization is there. Maybe sometimes we can embolizing agent can go to the cystic artery. So if bleeding occurs, then definitely it will help. But preemptive, in my opinion, like we should avoid it.
Can I just, I'll totally agree with Dr. Ajit. You see, whenever the patient is bleeding, irrespective of the cause, the first primary aim is to control the bleeding. In case the patient has parameters which are not congruent with the safety of the IR procedure, which you very rightly said, platelet count of 50,000 and INR of 1.5 and more, we do it under the cover of fresh frozen plasma. You can start FFP, but control of the bleeding remains the primary modality. As I said, it has to be high risk consent, because altered parameters can be controlled medically, but bleeding cannot be controlled medically. And as you very rightly said, there is absolutely no role of prophylactically embolizing, because embolization may have collateral side effects. You may have ischemia. And we have seen in our patient who have massive bleeding after papillotomy. If you go and do, you may plan to do a selective and super selective embolization, but it will have collateral damage, including ischemic necrosis. So prophylactically, it's never done. Unless you have things like huge hemangioma in the liver, which you want to resect. That is one indication. You have a exophytic hemangioma in the liver, which you want to embolize first and then resect it. That is one of the indications. You can do a prophylactic embolization of the lesion before removal to shrink it in size.
Thank you, sir.
I'd like to ask a question to Dr. Rajiv. Since this is the age of social media, many a times we consult over social media and WhatsApp and Viber. So what are the legal implications and what are the words of caution for us from a legal viewpoint?
Thank you very much for the relevant question for the current scenario. As we don't have any such laws prevailing in Nepal, and we have very little documents regarding the cyber security and the safety of cyberspace and relating to the social medias. I cannot, as such, I cannot say what will be the implications, but coming to and looking some of the cases which were filed before in District Court Kathmandu, we can say that, at least for now, we can say that the doctors or the medical practitioners who are providing free advice or some free treatment protocols in social media, and if somebody follows that correctly or maybe incorrectly, and there were some consequences or implications to that, they have come to the court. That has been said, that we have found as example. But what were the verdict? Like district courts, usually they don't provide verdicts. They decide something. Most of the courts have, in that scenario, they have decided that this case to be settled by Nepal Medical Council in our context. So such cases have not yet reached to Supreme Court, and there are no clear-cut Supreme Court verdicts to make such laws in Nepal. Thank you very much.
अब गोविन्दजीलाई म लास्ट क्वेसन सोध्छु एउटा, देन maybe then we close the floor. सर, हामी हस्पिटलमा बिरामी भन्न गर्दाखेरि चाहिँ सुरुमा चाहिँ बेहोस गराई वा नगराई यो शल्यक्रिया अथवा अन्य चाहिँ हामी ट्रिटमेन्टहरू गर्न राजी मन्जुरी दिएछु भनेर भने हुन्छ हैन. अब त्यो बिरामीलाई इन्डोस्कोपी गर्ला, कोलोनोस्कोपी गर्ला, कुनै एउटा चाहिँ सानो एब्सेस ड्रेन गर्ला हैन, त्यो कन्सेन्टले चाहिँ त्यो सबै प्रोसिजर कभर गर्छै गर्दैन. फर्स्ट क्वेसन. अनि सेकेन्ड क्वेसन चाहिँ मानिलियो कि हामीले इन्डोस्कोपी गर्यौं तर कन्सेन्ट लिएको थिएन, बिरामीलाई केही भयो हैन, अनि हामीले चाहिँ भोलि कोर्टमा गएर चाहिँ उसले मानेर त मैले गरेँ नि, त्यो त उसले गर्छु भन्यो अनि मैले गरे हो, न त किन सूचित हो, कन्सेन्ट त दिएकै हो नि, तर डकुमेन्ट पो गरेको छैन भन्न पाइन्छ कि पाइँदैन?
थ्याङ्क यू भेरी मच सर, एकदम इन्ट्रेस्टिङ कुरा. मैले त्यही भएर अघि कन्सेन्टलाई टु साइडेड सर्ड लेख्नुको कारण पनि यस्तो, कन्सेन्ट कुनै हिसाबले कन्ट्र्याक्चुअल डकुमेन्ट पनि हो, कुनै हिसाबले होइन. किन भन्दाखेरि हामीले कसरी कन्सेन्ट बनाउँछौँ भन्दाखेरि हामीले चाहिँ पेसेन्टको तर्फमा चाहिँ सबै कुरा लेखेको हुन्छ. जस्तो यो प्रोसिजर गरिनेवाला छ, यो प्रोसिजरको कन्सिक्वेन्सेस यो हुनसक्छ, इभन डेथ हुनसक्छ, मृत्यु भएमा अस्पताल डाक्टरलाई कुनै दोष दिने छैन, हाम्रो खालको कन्सेन्ट चाहिँ यो. तर आइडियली कन्ट्र्याक्चुअल डकुमेन्ट हो भने त कन्ट्र्याक्टमा जहिले पनि 3टा कम्पोनेन्ट हुन जरुरी छ. एउटा भनेको प्रपोजल, अर्को एक्सेप्टेन्स, त्यसपछि कन्सिडरेसन. यसमा प्रपोज कसले गर्यो त पेसेन्ट पार्टी ट्रिट गर्न आउनु या उसले चाहिँ मेडिकल हेल्प सिक गर्नु भनेकै हामी चाहिँ इम्प्लाइड कन्सेन्ट भन्ने बुझिरहेछौँ. तर यदि हामीले ब्ल्याङ्केट अप्रोचमा गर्ने हो भने चाहिँ त्यो ब्ल्याङ्केट अप्रोचको लागि हामीले जे गर्दा मिस्याप भएको थियो त्यो कुराको कन्ट्र्याक्चुअल डकुमेन्ट होइन भनेर चाहिँ कोर्टले लिएको उदाहरण छ. इभन ब्रिटिस कोर्टमा पनि यो कुरा गएको उदाहरणहरू प्रशस्तै छ. ब्ल्याङ्केट अप्रोचमा कन्सेन्ट लिँदाखेरि चाहिँ त्यो कन्सेन्ट इनिसिएसन अफ ट्रिटमेन्टको लागि थियो तर यहाँसम्मको थिएन भन्ने चाहिँ यो चाहिँ हामीसँग भर्डिक्ट अभाइलेबल छ. त्यसैले ब्ल्याङ्केट अप्रोच अफ कन्सेन्ट चाहिँ सकेसम्म युज नगरेको राम्रो, तर अब प्र्याक्टिकल्ली त्यो हामीले गरिरहेको कुरा हो. त्यसपछि कमिङ इन्टु नेक्स्ट क्वेसन, जस्तो मैले त्यही भन्दैछु, सरले भन्नुभयो जस्तो इम्प्लाइड कन्सेन्ट, त्यसपछि अर्को चाहिँ इम्प्लाइड या भर्बल भनौँ, इभन भर्बल कन्सेन्ट या रिटर्न कन्सेन्ट. अब यो 3टा मध्येमा आइडियली इम्प्लाइड कन्सेन्टको लागि चाहिँ हाम्रो 4 एस्पेक्ट्स अफ फिजिकल एक्जामिनेसन, त्यतिभन्दा बढीलाई इम्प्लाइड कन्सेन्ट इज सफिसियन्ट भनेको छैन. अझ कति कन्ट्रिजहरूमा त यो पनि भएको छ कि इभन फर पर्कसन एन्ड अस्कल्टेसन यु निड टु हेभ एटलिस्ट भर्बल कन्सेन्ट. इन्स्पेक्सन पाल्पेसन क्यान बी डन विथ इम्प्लाइड कन्सेन्ट. तर हाम्रो कन्टेक्स्टमा चाहिँ स्टिल आई थिङ्क भनौँ न त्यहाँसम्म नभएको हुनाले तैपनि इम्प्लाइड कन्सेन्टलाई कुनै पनि इन्टरभेन्सन एटलिस्ट डायग्नोस्टिक होस् या थेरापेटिक होस्, इम्प्लाइड कन्सेन्ट चाहिँ के अरे सफिसियन्ट चाहिँ छैन. थ्याङ्क यू सर.
So now I think we close this session and move to the closing remark by Dr. Mukesh.
Thank you, speakers and chairperson. Now I would like to call on the stage our chairpersons to provide certificate and token of love to our speakers. I would like to request Dr. Ajit Khanal to provide token of love and certificate to Dr. Achalasia Kashyap. Dr. Yuvraj to Dr. Ramakrishna Bharat. Also to Deepshika Nirola. I would like to request Dr. Dilip Neopani to provide token of love and certificate to Dr. Ajit Thapa and Dr. Rajiv Rizal.
Thank you so much, speakers and the chairperson of the session. Now, I guess the most important and the most awaited session of today's event is the award distribution for the winners of the endoscopic video competition. We request judges Dr. Umid Shrestha, Dr. Bikram Pradhan and Dr. Yuvraj Sharma to provide award to the winners of the endoscopic video session. And to the note, the award is being sponsored by Saili Endoscopy. The first prize, the winner, the prize for first prize is the cash prize of 25,000, and the award goes to Dr. Savin Raj Bhandari from Bir Hospital. Second prize is the cash prize of 15,000, and the winner is Dr. Shivam Chaurasia. Third prize is the cash prize of 10,000, and the winner is Dr. Sujan Chandra Paudel.
all the winners. Now we request Dr. Bhupendra Kumar Bosne to distribute the certificate for today's sponsors. I would like to invite representative of the following to come on stage and receive their certificate. Representative from Himalayan Medical Distributor. Representatives from the Himalayan Medical Distributor. Representatives from National Electoral Lottery. Representatives from RB Merchant. Representatives from Torrent Pharma. Representatives from DZPL. Representatives from Asian Pharmaceuticals. Representative from Axis Trade Link. Representative from Axis Trade Link. Representative from Prasan Enterprises. Representative from Dr. Reddy's. Lastly, representative from Helium Medical Technologies. Representative from Dr. Reddy's. Thank you, sir. Now we also have another event, that is Lucky Draw program being organized by DZPL. We'd like to request the representative from DZPL to come forward and announce the winners.
Dr. Shankar Baral. Dr. Shankar Baral. Dr. Susil Parazuli, TUTS. Dr. Susil Parazuli. The first prize, no? Yes,
Congratulations, Dr. Susil Parazuli. Azulai.
Thank you.
Thank you.
We also have a program by Asian Pharmaceuticals.
Good evening, doctors. So we are going to do the lucky draw. We have two prizes. Both are equal. And so we are going to open this sealed box of Pantop. And pour it down to this bucket. So I'd like to do the honors. Sir, sir, please. Ekdam, sir. Nikalne parcha, please. So we have two prizes. One is of Esotop Fast and of Pantop D from Asian. Oh my God! Number no, then just the last.
I cannot say the name, you know. It's really fantastic. Dr. Bhupendra Basnet. Yes, I want to go. It's true. It's true. It's real. सधैँ मलाई भन्नुहोस् ओ बधाई
एकैचोटिमा फेर्दै भने Congratulations, sir. Congratulations. Badai, sir. So another lucky winner.
From Star, Srijan Man Pradhan. Srijan? Srijan?
So we'll take couple of count garam. Dr. Srijan Man Pradhan 1, Dr. Srijan Man Pradhan 2, and Dr. Srijan Man Pradhan 3. Unundai. Let's proceed to another lucky winner for Esotop Fast. And the winner is
Dr. Ramesh Rana from He's there. Okay, he's here. Lucky.
The lucky winner of Esotop Fast from Asian, Dr. Ramesh Rana from Dulikhel Hospital. Congratulations, Dr. Ramesh Rana. Congratulations, sir. Thank you very much, sir. Thank you. Thank you very much for listening, sir. Thank you. Thank you. Have a nice evening, sir.
Once again, congratulations to all the winners. Now, without further delay, may I now request Dr. Mukesh Sharma Paurel, Head of Department of Gastroenterology, Bir Hospital, for his closing remarks.
Thank you, Dr. Anju and Dr. Narayan, for splendidly conducting today's all sessions. Now, respected teachers and my dear colleagues, as we conclude Gastro Update 2025, I want to extend my heartfelt gratitude to all of you for making this event a huge success. It has been an incredible day filled with insightful discussions, cutting-edge advancements, and hands-on experiences. A special thank you to our esteemed national and international speakers who have shared their expertise and perspectives, enriching our understanding of the evolving landscape in gastroenterology. To our participants, your enthusiasm, engagement, and dedication to advancing patient care are what makes events like this
meaningful. We hope today's discussions will inspire new approaches and collaborations in your practice. I also want to express our sincere appreciation to the faculty and staff of the Department of Gastroenterology, Bir Hospital, as well as TUTH, for their commitment and hard work in organizing this event. A big thank you to our research and development team members of NAMS for their support. And of course, a big thank you to our generous sponsors, RBI, Boston Scientific, Fusinon, Torrent, DCPL, Dr. Reddy's, Big Rip, Siley, Asian, and Dawn Medical Technologies for their support in making this conference possible. Thank you all once again for being a part of Gastro Update 2025. Now for a very special event, I'd like to invite Dr. Bhupendra Basnet to the dais.
Thank you, Dr. Mukesh. We are at the end of today's program. This became our calendar event since 2017, this Gastro Update. This year, Bir Hospital has completed this task. Next year, TU Teaching Hospital, Dr. Raul will carry on. Today is what's a amazing coincidence, I don't know. One of our mentor, our teacher, has a special day, his birthday. So we are arranged this cake for him. Wishing a very, very happy birthday. Dr. Anil Arora, sir. Please come to the cake. And all the seniors who are in the front row, please come to here. Dr. Dinesh, Dr. And I would like to Dr. Sasi to hand over the cap. Happy birthday to Dr. Anil Arora, sir. Would you like to say something, sir?
I think more than the birthday wishes, I'm so glad to see the gastroenterology flourishing like my birthdays. I'm 64. I think the way it has come up in leaps and bounds, it gives me big pleasure rather than cutting this cake. I must congratulate all the mentors, all the senior people, starting with Dr. Achalasia, who is repeatedly being missed, Dr. Shashi Thapa, Dr. Dinesh, Dr. Chaudhary, and everybody else who has contributed to it. And was amazed. I think the level of presentation, the type quality of lectures and the knowledge is no less than what we see in our Indian conferences. So this is one of the rare conferences in which I have attended from top to bottom, sitting all the way. I'm really proud of all the people who have made this as a successful event. Congratulations to all, and our doors in Gangaram are open for all the upcoming gastroenterologists to come and have training with us at any point of time. As much as we learn from the Western world, being our own neighbor, you're always welcome to come and share your experience. And the way you have grown up, I think it gives me a sense of fulfillment and enjoyment that we are at par now in terms of the quality and presentation. Congratulations to all.
Thank you, sir. Just a minute. Professor Andrew Elder, President of Royal Currency, is also here. Please come to join Dr. Arora's birthday. Just come join, sir. Come to join, sir. Okay. Happy birthday to you. To you. Happy birthday to you.
Happy birthday to you. Happy birthday to you. Happy birthday, happy birthday, happy birthday.